Psychiatry is a very important subject, not from exam point of view, it's also in personal life. Before exam, apart from knowledge, you will require a lot of calmness and how to approach, have a good strategy before, this exam, few days left. So I hope you are prepared. So shuru kare. If we are going, okay, so basically in Indian exams, yeah, in our Indian exams, they don't change the topic, they change the MCQ. So the previous year's topics are very, very important. These are the high topics, you have to target them. So specifically before, I will give you some take home message, and one important point is, revise the previous year high topics. Have a good concept in those topics, have a good hold on those topics. That's very important. If you'll go for the first MCQ, which drug we used as a anti-smoking agent? Acamprosate, busulfan, the varenicline and gabapentin. देखिए एडिक्शन साइकेट्री दे रियली आस्क एवरी टाइम 1 or 2 MCQ दे आस्क फ्रॉम द एडिक्शन साइकेट्री. तो एडिक्शन साइकेट्री को आपको मिस नहीं करना है. एडिक्शन दिस इज 1 MCQ, बट व्हाट आई विल ट्राई टू गिव यू द important points of the whole topic. In every topic we'll try to do that. Okay, anti-smoking. So if we'll talk about the nicotine dependence, so the first MCQ about it, it's a most commonly used substance in India. Most commonly used substance in India. ये आप ध्यान रखना. वैसे भी जैसे हम sometime they ask this MCQ की मोस्ट कॉमन साइकेट्रिक डिसऑर्डर. सो मोस्ट कॉमन साइकेट्रिक डिसऑर्डर इंडिया में जैसे एक निमांस में स्टडी हुई थी, अगर आप देखोगे कि अगर टोबैको इज गिवन इन द ऑप्शन, यू हैव टू गो फॉर द टोबैको. सो टोबैको यूज इज मोर कॉमन इवन इन देन द इवन डिप्रेशन. आप वैसे देखते हो तो हाँ, एंजाइटी डिसऑर्डर इज द मोस्ट कॉमन, मूड डिसऑर्डर इन द डिप्रेशन इज अ सेकेंड. बट अगर आप अलग अलग एंजाइटी और मूड डिसऑर्डर में भी देखते हो तो ये बड़ा ट्रिकी MCQ है, ये ध्यान रखना. अगर एज ए होल ग्रुप एंजाइटी डिसऑर्डर पूछें, सो मोस्ट कॉमन एंजाइटी डिसऑर्डर, देन यू विल गिव द आंसर द डिप्रेशन. बट अगर अलग अलग एंजाइटी डिसऑर्डर सपोज दे दिया आपको, स्पेसिफिक फोबिया, डिप्रेशन, ऐसे, तो डिप्रेशन इज इवन मोर कॉमन देन इन योर स्पेसिफिक फोबिया. ये आपको ध्यान रखना है. एंड अगर टोबैको आंसर दिया हुआ, यू हैव टू गो फॉर द टोबैको इवन मोर कॉमन देन डिप्रेशन. तो इट्स अ मोस्ट कॉमनली यूज सब्सटेंस. इसमें अगर वो आपसे पूछते हैं कि विड्रॉल सिम्टम्स में, आपको पता है हम ज़्यादा डिटेल में नहीं जाएंगे, बट आपको क्या ध्यान रखना है, एक ओनली वन पॉइंट यू हैव टू रिमेंबर, दैट यस वी हैव इरिटेबिलिटी, वी हैव डिक्रीज अटेंशन, कॉन्सेंट्रेशन. ओके, सबसे important point, most of the addiction psychiatry, most of the substance we see that withdrawal symptom, usually we have palpitation, the tachycardia, but in nicotine dependence we have withdrawal symptom as a bradycardia. So you have to remember that, that's very important, bradycardia. Okay, withdrawal symptom. अगर ट्रीटमेंट की हम बात करें निकोटीन डिपेंडेंस में, that what treatment we give, yes, one is bupropion. Already मैंने आपको, bupropion is NDRI, norepinephrine dopamine reuptake inhibitor. bupropion की 2-3 इंपॉर्टेंट बातें हैं, आपको ध्यान रखना कि yes we use as a एंटी स्मोकिंग एजेंट, क्योंकि ये डोपामिन के लेवल को इंक्रीज करता है. दूसरा आपको ध्यान रखना, इट्स हैविंग अ लीस्ट सेक्सुअल साइड इफेक्ट, लीस्ट सेक्सुअल साइड इफेक्ट अमंग एंटी डिप्रेसेंट. ये भी MCQ कई बार पूछा जाता है. एंड द थर्ड, इट इज कॉन्ट्राइंडिकेटेड इन एपिलेप्सी. ये आपको ध्यान रखना, ये एपिलेप्सी में बुप्रोपियोन नहीं दिया जाता. सो वन बुप्रोपियोन वी यूज. अनदर वी यूज निकोटीन रिप्लेसमेंट थेरेपी. निकोटीन रिप्लेसमेंट थेरेपी, वी गिव निकोटीन इंस्टेड ऑफ निकोटीन. तो वो पूछते हैं कि निकोटीन किस किस फॉर्म में आती है. निकोटीन वी यूज़ इन अ फॉर्म ऑफ गम्स, इसकी च्युइंगम आती हैं 2 मिलीग्राम एंड 4 मिलीग्राम. ओके, इसके पैच आते हैं, इसके इनहेलर आते हैं, ओके, इसके लोजेंजेस आते हैं। तो वी हैव गम्स, पैच, इनहेलर, लोजेंजेस। आपको अगर पूछा जाए, प्लीज रिमेंबर दैट इट डजंट कम इन अ टेबलेट फॉर्म। निकोटिन रिप्लेसमेंट थेरेपी डजंट कम इन अ टेबलेट फॉर्म, ये पॉइंट आपको याद रखना है। एंड देन द एमसीक्यू आवर वाज कि इसमें कौन सा ऑप्शन होगा? आंसर विल बी सी, वेरेनिक्लिन। वेरेनिक्लिन आपको ध्यान रखना है कि इट्स अ the mechanism of varenicline is it's a alpha 4 beta 2 partial agonist. ओके, इट्स अल्फा 4 बीटा 2 पार्शियल एगोनिस्ट। इसकी 3 मंथ्स की थेरेपी होती है। इनिशियली वी गिव 0.5 मिलीग्राम फॉर 3 days, मॉर्निंग एंड इवनिंग। देन वी गिव 0.5 milligram and 1 milligram for 4 days, and then from 8th day we give 1 milligram in the morning and 1 milligram in the evening from the 8th day. It's a 3 months therapy we have, very good medication, very useful. Okay, so ये आपको याद रखना है। Once we are talking about tobacco, nicotine, तो हम important points सारे सब्सटेंस के कर लेते हैं। द फर्स्ट इज एल्कोहल। एल्कोहल में आपको याद रखना है, वी हैव अ सिंपल विड्रॉवल सिम्टम एंड वी हैव कॉम्प्लिकेटेड। वी हैव सिंपल एंड वी हैव कॉम्प्लिकेटेड। ओके, okay, so simple and complicated. In complicated, simple withdrawal symptom is tremor, palpitation, increased blood pressure, headache, sleep disturbance, okay, nausea, vomiting, simple. बस एक MCQ, one MCQ you have to remember that tremor is a most common withdrawal symptom in alcohol. One point you have to remember. One more MCQ here, that there are two important MCQ. One, if they ask most common withdrawal symptom in alcohol, tremor. If they ask most common withdrawal syndrome, then guys, you have to answer hangover, because hangover is a not only one symptom. In hangover we have a nausea, we have a headache, so it's a combination. So most common withdrawal symptom tremor, most common withdrawal syndrome hangover. Okay, in complicated, that I want to tell you, and this, please, I humbly request you, please remember this table, because this table, one or another exam in last 2-3 years, they continuously asking the MCQ from this table. So you have to be very careful about this MCQ. Complicated withdrawal symptom means more severe, more dangerous if you will not handle in a appropriate manner. So 3 important complicated or more severe withdrawal symptom we have in alcohol. Alcohol withdrawal seizure. The first is alcohol withdrawal seizure, alcohol withdrawal delirium, and alcoholic hallucinosis. That is very important. Okay, alcohol withdrawal seizure. Patient having once person is dependent, suddenly abruptly stop the alcohol, he or she will have seizure. This seizure always 2 or 3 in a number, so it's dangerous. Once the person is alcohol dependent, better to treat him. Alcohol withdrawal seizure, the Usually they ask, usually when it occurs between 12 to 48 hours. That you have to remember. That between the peak of alcohol withdrawal seizure after stopping alcohol between 12 to 48 hours. That time is very important, you have to see. The peak of alcohol withdrawal delirium is, usually we say, between 2 to 5 days. Okay, usually we say 48 hours to 72 hours, up to 5 days is where, but maximum it can occur up to 7 days. That you have to remember. Why it's important, I'll tell you. So the peak of alcohol withdrawal delirium is between 2 to 5 days, roughly. Like sometimes they say 48 to 72 hours, sometimes they will say 2 to 5 days. This is a peak time. Maximum it can occur, alcohol withdrawal delirium, up to 7 days, not beyond that, after stopping alcohol. And alcoholic hallucinosis, it is within 24 hours. Within 24 hours. Okay, within 24. So this is the first. Duration will give you hint in the MCQ. Now the treatment in alcohol withdrawal seizure, treatment is IV diazepam. Basically it's a alcohol withdrawal seizure, it's a withdrawal symptom, it is not a epilepsy per se, so no anti-epileptic. That you have to remember. Sometimes what happens, that we start anti-epileptic these patients, we should not. Our aim is to terminate the episode, that time, that's it. Okay, so IV diazepam you give to terminate the episode, that's it. No anti-epileptic in alcohol withdrawal seizure. Alcohol withdrawal delirium, another name of alcohol withdrawal delirium, you know what is that? That is delirium tremens. Okay, delirium tremens. The peak is between 2 to 5 days, maximum up to 7 days. The treatment, what we give in alcohol withdrawal delirium, long acting benzodiazepine. Okay, long acting benzodiazepines like chlordiazepoxide and diaze, that you have to remember. Okay, long acting benzodiazepine, chlordiazepoxide and diazepam. Alcoholic hallucinosis, patient will say, sir, whenever I stop alcohol, I start hearing voices. मुझे आवाजें आनी शुरू हो जाती हैं. When I take alcohol, I don't hear any voice, so I keep taking alcohol. What I'm trying to say, guys, I'm trying to say that sometime alcoholic hallucinosis become as a reinforcer for taking alcohol. Patient doesn't know what is hallucination. He understand ki when I take, I'm okay. When I don't take, I start hearing voices, so better to take. Okay, 2-3 MCQs here, 2-3 important concepts. First, if they ask which of the following complicated withdrawal symptom appear earliest, your answer should be alcoholic hallucinosis, because it occurs within 24 hours. First point. Second point, in alcohol withdrawal delirium, in delirium we'll talk about that. In delirium also we have hallucinations and delusion. In alcoholic hallucinosis also we have hallucination, auditory hallucination. Then how you differentiate between alcohol withdrawal delirium and alcoholic hallucinosis? So first important, yes, you can say time, it occurs within 24 hours and it occurs between 2 to 5 days, usually 48 to 72 hours. But see, the patient who are severely alcohol dependent, they can, in those patients, the alcohol withdrawal delirium or delirium tremens can occur early also. So then the timeline is not a differentiating point. Then how you will differentiate? Remember, alcoholic hallucinosis patient will come to you himself or herself. They will complain about auditory hallucination by themselves. What does that mean? That means that they don't have any impairment of consciousness. They are fully conscious. So the alcoholic hallucinosis is what? No impairment of consciousness, guys. Please remember, that is very important point. So no impairment of consciousness. No impairment of consciousness. Patient is fully conscious in alcoholic hallucinosis. Only symptom is what? Auditory hallucination. In alcohol withdrawal delirium, the cardinal feature of delirium is what? The main feature of delirium is what? impairment of consciousness. So in alcohol withdrawal delirium, patient will be, you know, not conscious, like there is an impairment of or clouding of consciousness, and in alcoholic hallucinosis patient will be fully conscious. Okay, in alcoholic hallucinosis, what treatment we give? The treatment we give in alcoholic hallucinosis is what? We give antipsychotics, because there are psychotic symptom hallucination, antipsychotics. Okay, and here I told you. So this again and again they just change the, you know, the line of the MCQ, and they're trying to ask, so that you, again I am saying, the last time I'm just repeating, it's a between 12 to 48 hours, it's between 2 to 5 days, this is within 24 hours. The treatment here we give only IV diazepam, here we give long acting benzodiazepines, and here we give antipsychotic. Clear? In the treatment, yes, in treatment of alcohol dependence, the first stage we go for what? Detoxification. In a treatment of alcohol dependence, detoxification again you do with the long acting benzodiazepines. You prefer long acting benzodiazepine because they have a long half-life and they cover the withdrawal symptom nicely. But please remember, the diazepam and chlordiazepoxide, they are contraindicated in the liver disease, and the alcohol dependent patient having a very high chance to have a alcohol liver disease. So in those patients, if you go for the long acting benzodiazepine, but if you don't have a facility of doing the investigation, you don't have a LFT report, a liver function test report in your hand, or if you have report and there is a derangement in LFT, then you have to go for lorazepam. Please remember. So usually we prefer the long acting, but lorazepam is safe in liver disease. That you have to remember. That's it. That's a one MCQ they can ask here. Detoxification. Apart from detoxification, after detoxification we go for what? Anti-craving agents. Anti-craving agents. Anti-craving agents we have what? Acamprosate. We have baclofen. Okay, we have topiramate, and we have naltrexone. Okay, please remember, acamprosate, it's a NMD antagonist. Okay, it's safe in liver disease. That you have to remember. So if they ask you that from first day when you start the detoxification, if you want to prescribe the anti-craving agent without having investigations in your hand, then which anti-craving agent you can prescribe? You can prescribe, guys, acamprosate. Okay, we give in the 333 milligram dose, and baclofen we give, then the topiramate, and then naltrexone. If they ask which antidepressant can act as an anti-craving agent, please remember fluoxetine. Fluoxetine has little anti-craving agent property, so that they can ask. Okay, clear? Yeah, guys. Okay, very good. Yeah, some the students also giving, you know, the answers also. Okay, guys, so keep tuned. Please ask if anything, and you know, the area we are covering, if you want me slow, fast, please let me know. I'll do that according to you. So this is anti-craving agent. The aversion therapy, if they can ask you, aversion therapy, what is aversion therapy? Aversion therapy, we use what? Disulfiram. Yes, aversion therapy we use disulfiram. Disulfiram basically inhibit the enzyme aldehyde dehydrogenase. Basically, that's why we are not able to metabolize further acetaldehyde. Acetaldehyde actually accumulate in our body, and acetaldehyde gives the reaction which we call what? Disulfiram ethanol reaction. Increased blood pressure, skin rash, patient will have nausea, vomiting, headache, severe headache, disulfiram ethanol reaction. Why we call it aversion therapy? Today, suppose patient, you are taking alcohol, and the family members, usually the disulfiram unfortunately is a medicine which always use given the surreptitiously, and the family members are giving surreptitiously, and suppose the person took the alcohol on top of disulfiram, and he or she had a disulfiramethanol reaction. So next time, even if you will look at alcohol, you will have, you know, aversion kind of reaction. That's why we call it a aversion therapy. There are some screening tests also, fast audit, you know, alcohol use disorder screening test, and those. So that you have to remember. Fatafat, if we'll talk about little bit, everything we can't, it's a sprint session, but I try to cover this opioid. In opioid, we have a natural opioid, we have a synthetic opioid, that you know, the morphine, okay, codeine, papaverine, these are the natural one, and we have a heroin or smack, the methadone, buprenorphine, you know, these are the synthetic one. Only you have to remember that what are the withdrawal symptom in opioid. The withdrawal symptoms are, we have rhinorrhea, okay, we have rhinorrhea, the you know, water from the nose, we have a lacrimation, watering the water from the eyes, we have a nausea, we have the important withdrawal symptom, we have a what, body ache, we have a increased blood pressure, we have diarrhea, okay, we have a diarrhea, okay, these are the body ache, increased blood pressure, diarrhea, these are the important withdrawal symptom. Apart from that, the other, as I told you, that we have a, you know, pupillary dilation, mydriasis, these are the important withdrawal symptom. In opioid dependence treatment, in treatment of opioid dependence, just you have to remember, before we were giving the combination of medication, like we were giving clonidine to decrease the blood pressure, we were giving the NSAIDs to decrease the body ache, and we are giving the lopramide to decrease the diarrhea, okay, yeah, correct. In but it has been seen that in the alcohol, withdrawal symptoms are not so severe, but in opioid the withdrawal symptoms are very severe, and that's why the new strategy came into the market, because many patients were stopping the treatment, and they were reusing the opioid, and that's why the new strategy came into the market. And what is that? Opioid substitution therapy. Opioid substitution therapy. Opioid substitution therapy. In opioid substitution therapy, we have methadone and buprenorphine. That you have to, methadone and buprenorphine. Methadone comes in a liquid form, 1 ml equal to 5 milligram, and buprenorphine comes in a tablet form, 2 milligram, 4 milligram, okay, yeah. Usually in our country, we prefer the buprenorphine. Buprenorphine is a very amazing, you know, the treatment for the opioid dependence patient. So opioid we are, you know, substituting opioid to the opioid. That's why we call it a opioids or OST, or opioid substitution therapy, okay. So these are the opioid, alcohol. There is even cannabis. What is the main compound of cannabis is what? Delta 9 tetra hydrocannabinol, okay. We have in cannabis what? We have a bhang, we have a charas or what, hashish, and we have what, ganja, okay. Bhang we get from the dried leaves, ganja we get from the what, female inflorescence, charas or hashish we get from the resinous extract, correct. Cannabis is a substance which causes more psychological dependence than physio, that you have to. If they ask you what are the other substance which causing the more psychological dependence than physiological, then your answer will be cocaine, LSD, lysergic acid, okay, amphetamine, cannabis, etc. Done? Yeah. No, cannabis is not legal, guys. Cannabis is legal. It's a most commonly substance which is illegal in India and used. So if they ask the most common illicit drug which is used in India, it is what? Cannabis. So it's not legal. Okay, people are using more than legal, but it is illegal. Okay. There are 3 syndromes associated with that. You please remember that: a motivation syndrome, okay, flashback phenomenon, okay, and run amok. That you have to remember. Okay, motivation syndrome, patient because of cannabis having a negative like symptoms of schizophrenia, unmotivated, flashback phenomenon, and run amok. That you have to remember. Run amok, like having a suicidal or homicidal tendency under the influence of cannabis. Okay, yeah. Flashback phenomenon also most commonly associated with what? LSD, but it is also associated with what? Cannabis. Done? Okay. If we'll go there, so the question number 1, the answer is, yeah, answer is C. True regarding somnambulism. It's a disorder of sleep arousal. Person will have fully consciousness, usually terminates in awakening followed by confusion, and there may be neurological condition associated with it. Okay guys, so please give the answer. Okay, try to give the answer. See, the sleep is a small topic but frequently targeted topic. So the briefly I'll tell you about the sleep. Okay, briefly. Okay, then we'll go for the answer. Okay guys, sleep. Sleep has a 2 stages. One is REM and second is what? NREM. NREM. Okay. REM, another name is what? Active sleep, paradoxical sleep. Then NREM, slow wave sleep, and orthodoxical sleep. Okay. REM, it's active sleep. The important point about REM that you have to remember, there is a frequent dreams. Shall I write everything or I just speak? Yes guys. So frequent dreams, patient will have frequent dreams, patient will have increased body temperature and cerebral metabolism. Okay. Cerebral metabolism. Patient have decreased muscle tone. Okay. Patient have morning penile erection, or we call it a genital tumescence. Okay, right. Okay, I'll write. So frequent dreams, increase body temperature and cerebral metabolism, decrease muscle tone, the penile erection. Usually these are the frequent characteristic of REM sleep. If they ask you, very important point I am going to tell you guys, please remember the disorders of REM sleep. The first is nightmare and second is narcolepsy. Nightmare, patient will have some kind of dreams and suddenly you will like it's a REM, it's a active sleep, it's a superficial sleep. Just you shake the patient and patient will get up and patient will remember about nightmare. That you have to, it's a very important thing. The patient remember about nightmare. Remember, because it's a active sleep, it's a superficial, it's a REM. Narcolepsy, again and again they are asking, so just we'll take 1.5 minutes for the narcolepsy. Okay, narcolepsy, it's a first point, it's a REM sleep disorder. The REM sleep disorder. Second, male female ratio is 1:1. The onset is around 20 years of. The symptoms of narcolepsy. What are the symptoms of narcolepsy? The first is sleep attack. Sleep attack. Sleep paralysis. Okay. Cataplexy and hypnagogic hallucination. Okay, tetrad of narcolepsy. Patient, because it's a REM sleep, because of REM there is a decreased muscle tone, so there is a sleep attack. Patient have a sleep paralysis. Patient is awake but patient is not able to move around. The cataplexy because of sudden decrease of muscle tone, and hypnagogic hallucination. As you know that hallucination, while going into sleep you have a hallucination. Hypnagogic, go means going into sleep. That's how you can remember that hypnagogic. And during awakening if you have a hallucination, it's a hypnopompic. The important point, in last 2-3 years again and again they targeted, and what they targeted, first thing, what important, the chemical we have in narcolepsy, there is a decreased level or deficiency of hypocretin. The important point, they ask that how many types of narcolepsy you know. Narcolepsy type 1 and narcolepsy type. Narcolepsy type 1, it's a narcolepsy with cataplexy. That you have to remember. Okay, and type 2 is narcolepsy without cataplexy. Very important point, guys. Please remember it. Remember by heart. We will open the paper and very high chance that they can ask. So narcolepsy with cataplexy is type 1. Narcolepsy without cataplexy is type 2. Hypocretin level. The hypocretin level is low in type 1 and hypocretin level is normal in type 2. These are the two important features between the type 1 and type 2. Yeah. Okay, type 1 and type 2. So type 1 is with cataplexy, type 2 is without, hypocretin level low, hypocretin level normal. Drug of choice of narcolepsy, it's a modafinil, CNS stimulant, modafinil. Clear? So that you have to remember. NREM, already as I mentioned, that it's a slow wave, it's a orthodox, it's a NREM, non-rapid eye movement. Please remember, before, according to classification, there were 4 stages and now we have only 3 stages. That you have to remember. Stage 1, stage 2 and stage 3. According to current standard classification, we don't have, that is, many students they are doing the mistake. Please don't do this. Before we had a 4 stages, now we have only 3 stages in NREM. Stage 1 we have theta waves. Stage 2 we have sleep spindles and K complex, and stage 3 we have delta wave. Before they were saying कि delta waves less than स्टेज 3 में क्या होता था, लेस देन 50%, स्टेज 4 में क्या होता था, मोर देन 50%. अब 3 और 4 को उन्होंने क्लब कर दिया एंड दे से कि ओके इट्स अ स्टेज 3. ये आपको याद रखना है, ठीक है. सो प्लीज इसमें वेव्स का मैं थोड़ा सा आपको बता देता हूँ जस्ट ब्रीफली दैट वी हैव अल्फा waves, we have beta waves, okay, alpha waves, beta waves, we have theta waves and we have delta. ये वो पूछ लेते, ठीक है. Alpha waves when the person is having a awake and alert and the patient, the eyes are closed. Person is awake, alert and eyes are closed. Okay. Beta waves as the person opens the eye, open. Okay, beta waves, correct? Yeah. And the theta waves, as I mentioned, that it's a stage 1 of NREM and delta stage 3 of in a deep sleep. In a deep sleep, when we have an initiation of sleep, that time we have a theta waves, and otherwise that. So the alpha waves, that sometimes they can are nowadays they are giving some the pictures and they ask which this is. So usually we have around 8 to 12 hertz frequency of alpha waves. Okay, around we have 14 to 30 hertz of a beta waves, correct? And we have 4 to 7 hertz of theta, and we have 1 to 4 hertz of delta waves. That also sometime you can ask. So gradually when you go from alpha to delta, the frequency actually decreases and the amplitude will be increased. So the waves will become more and slower, and in alpha it's a little fast and the narrower, you can say. That's how you can recognize in the pictures. Okay, the disorders of NREM sleep. Disorders of NREM. Nightmare we had in a REM, we have a night terror. Night terror. Okay, we have sleep walking, sleep talking. Okay, bruxism, and we have nocturnal and uris. Okay, night terror we have in a NREM sleep. Sleepwalking, somnambulism, sleep talking, somnolique. Okay, okay, bruxism, teeth grinding. Bruxism. Nocturnal enuresis, the child passes the urine during night time. Okay, nocturnal enuresis. ये आपको याद रखना है. 2 और MCQ आप यहाँ पे याद रख सकते हो. 2 MCQ you can remember. Bruxism, they can ask that in which stage of NREM it occurs, stage 2. And nocturnal enuresis, the cutoff age is what? 5 years. 5 years. If they ask the drug of choice, desmopressin, and if they ask the treatment of choice, behavior therapy, alarm therapy. Okay, alarm therapy or behavior therapy. The drug of choice, yes, before we were using imipramine and all those amitriptyline, these drugs, but now we use desmopressin. Nasal spray we started using, but nasal spray gives the side effect nasal bleeding. That also you have to remember. So initially we started using nasal spray of desmopressin, but it was giving the nasal bleeding as a side effect, so we shifted to the oral tablets. Okay guys, so this is the REM and NREM sleep. Done? Okay, next more MCQ is there, so that we'll discuss later. So this is the about Alarm based. Correct. Very true. So this is a second. I hope we are going fine. Guys, are you there? Are you awake? Are you listening to me very clearly? We have lot to discuss still. Okay. So yeah, this is a disorder of sleep arousal. Yes. Usually terminates in awakening followed by confusion. Yes. There may be neurological condition associated with it. Yes. Neurological conditions like the temporal lobe epilepsy. We have complex partial seizure. There we have this somnambulism. So in somnambulism also sometimes you do the EEG and there is a finding of seizure. So the neurological conditions are associated. The person will have fully consciousness. No, person is not. It's a disorder of NREM. Person will be in the sleep. So person will not be fully conscious. So answer will be A, C, D. B is not correct. So okay, so it's a INICET or you can say PGI style MCQ. Okay, which of the following is not a risk factor for delusional disorder? Which is not a risk factor for delusional disorder? What are the risk factors for delusional disorder? Delusional disorder, पहले तो आपको पता होना चाहिए कि what is delusional disorder. We have schizophrenia and we have delusional disorder. Just a second, we'll go there and we'll discuss properly. Okay, so schizophrenia and delusional disorder. Yeah. Delusional disorder and schizophrenia. We have usually single delusion in delusional disorder or related delusion. Okay, related delusion. In schizophrenia, we have delusions, hallucinations. So you can say schizophrenia is a more severe psychotic disorder, delusional disorder is a less severe psychotic disorder. Okay. In delusional disorder, the duration we require for what? 1 month in DSM and 3 months in ICD. That you have to remember. Okay. Only one delusion, no other hallucinations and psychotic symptom. When you talk about the delusion, patient will talk about about delusion and he will or she will try to convince. So for example, a lady saying that whenever she go to job regularly on every day, somebody is following her. Sir, I think he wants to harm me or he wants to kill me. Delusion of persecution. But she is going regularly to the job. She is well groomed, no other hallucinations, no other psychotic symptom. So delusional disorder is a less severe psychotic disorder. Only one delusion examiner will talk about. Other domains will not get affected. No other psychotic symptoms and hallucination. Okay, dear students. And the duration in according to DSM we usually use 1 month. In ICD we use 3 months. Okay. Treatment, antipsychotic. But they ask that what are the risk factor in a delusional disorder. So in the risk factor we have one is the given. Yeah. So recent immigration, yes. Family history of delusional disorder or psychotic, yes. Social isolation, yes. Not the young age, the advanced age. So this will be the wrong. The advanced age will be the option. Okay. Apart from that, another risk factors of delusional disorder is sensory impairment. Sensory impairment. Okay, sensory impairment. That you have to remember. And some personality characteristics like interpersonal sensitivity, interpersonal sensitivity. So interpersonal sensitivity, sensory impairment, advanced age, recent immigration, family history, social isolation, that you have to remember. In schizophrenia, what briefly they can ask about schizophrenia, that in ICD and DSM. In ICD we have a two diagnosis, important one, what? Schizophrenia and acute psychotic disorder. Okay guys, acute psychotic disorder. Schizophrenia in ICD, how we make a diagnosis? 1 month or more. 1 month or more. And in acute psychotic disorder, acute and transient psychotic disorder, the symptoms are there, symptoms are same, but it is less than 1 month. It is less than 1 month. Okay. Acute and transient psychotic disorder, remember one stressor they usually give. Usually they start MCQ with the like fever. They will say the person had a fever, after a few days he started having a, the muttering to self. They will describe the some hallucinations, perplexity, that delusions, sleep disturbance, some kind of the abnormal behavior, and then they will say what's your diagnosis. So that you have to remember that according to which classification they are asking. If yes, according to ICD, schizophrenia is 1 month, and acute psychotic or acute psychosis they can say, or they can say acute and transient psychotic disorder. Acute and transient psychotic disorder. In DSM, there are three important diagnoses we have. One is what? One we have schizophrenia. Second we have what? Schizophreniform disorder. And the third we have what? Brief psychotic. Okay guys, brief psychotic disorder. Schizophrenia in DSM, how we make a diagnosis? It's 6 months. And schizophreniform 1 to 6 months. And brief psychotic disorder less than 1. Yeah. DSM also says that in these 6 months, if active symptoms are 1 month, and 5 months if even the other less severe symptoms are there, still you can make a diagnosis of schizophrenia. So that you have to remember that usually we use the criteria of 6 months in DSM, बट DSM भी कहता है कि भाई 6 महीने में से 1 महीने अगर एक्टिव सिम्टम्स हैं, एक्टिव सिम्टम जो डिल्यूजन्स, हेलुसिनेशन जिसके बेस पे हम डायग्नोसिस बनाते हैं, एंड 5 मंथ्स अगर लेस सीवियर सिम्टम भी हैं, स्टिल यू कैन गो फॉर द डायग्नोसिस ऑफ शिजोफ्रेनिया. याद रखना DSM 5 एंड ICD 11 ये क्या है? दीज आर द न्यू our newer classification of, or new addition you can say, in the current which we are following, ICD 11 and DSM 5. इसमें 2-3 चेंज मैं आपको बता दूं. एक तो चेंज क्या किया है इन्होंने, नो सब टाइप्स. अब शिजोफ्रेनिया की सब टाइप्स नहीं है. शिजोफ्रेनिया इज शिजोफ्रेनिया. पहले हम कहते थे पैरानोइड, हेबेफ्रेनिक, कैटाटोनिक, सिंपल, अनडिफरेंशिएटेड. नाउ शिजोफ्रेनिया इज शिजोफ्रेनिया. ओके, या different type of delusional disorder, guys. It will be little lengthy, but yes, I can if you want, the briefly we can go. So okay, so there will be no subtypes, no subtype now in schizophrenia, ICD 11 and DSM 5. And the second is, okay, don't worry Dipanshu, I'll try. Okay, just 2 minutes. Okay, so no subtypes. This is the first. Now schizophrenia is schizophrenia. The data don't support the various सबटाइप्स ऑफ शिजोफ्रेनिया. सो अब DSM 5 और ICD 11 कहती हैं भाई इसको सबटाइप नहीं है. ठीक है. एक जस्ट one more important concept, what are the changes, because recent changes they always ask, ICD 11, DSM 5, they try to hit those areas. So when we say schizoaffective disorder, schizoaffective disorder, in schizoaffective disorder, what, as the name suggests, schizo and affective. So there is a combination of schizophrenia and mood disorder. In mood disorder, either there will be depression or there will be mania. So we say schizoaffective depression type or schizoaffective mania type. Okay, yeah. पहले क्या होता था? Suppose a patient having a schizophrenia since 2 years. In 2 years, if he or she is fulfilling either one episode of depression, episode of depression हम कितने देर का बोलते हैं? How we make a diagnosis of depression? 2 weeks, correct? The duration criteria for depression is 2 weeks. Or there is a 1 week of mania. Duration criteria for mania is what? 1 week. So either person is having in 2 years 1 episode of depression or 1 episode of, हम इसको क्या बोल देते थे? Schizoaffective. Cross sectionally. Now DSM-5 and ICD-11, what they say? They say that no, if suppose patient having the duration of schizophrenia symptom in one particular patient is roughly, like 2 years suppose, then if you have to make a diagnosis of schizoaffective, so that depressive symptom or the manic symptom should be almost for 2 years. It's not like once he or she fulfill the criteria of depression or mania and you are making him, the schizoaffective disorder patient. No, you can't do that. So you just remember one line for exam point of view, that now schizoaffective disorder is longitudinal diagnosis. Longitudinal diagnosis rather than cross sectional. What does that mean? That mean, dear students, दैट अब हम एक बार एपिसोड फुलफिल करने से डिप्रेशन और मेनिया का हम इसको सीजोअफेक्टिव नहीं बोलते. वो कहते हैं कि सीजोफ्रेनिया के लगभग बराबर आपके सिम्टम डिप्रेशन या मेनिया के होने चाहिए, तभी आप इसको सीजोअफेक्टिव डिसऑर्डर बोल सकते. ओके, द मेडिकेशंस वगैरह वो तो फिर बड़ा वो लेंदी हो जाएगा, बट दिस इज अनदर एरिया जो आपको पता होगा. एक्यूट डिस्टोनिया, एकैथीजिया इज द मोस्ट कॉमन द साइड इफेक्ट ऑफ टिपिकल एंटीसाइकोटिक. एक्यूट डिस्टोनिया विद इन 2 weeks. These are the areas there they ask. If I'll tell you, याद रखना कुछ 3-4 इंपॉर्टेंट पॉइंट. क्लोजापिन एक तो क्या है जो ट्रीटमेंट रेजिस्टेंट शिज़ोफ्रेनिया में हम यूज़ करते हैं. ओके, क्लोजापिन इट्स अ एंटी सुसाइडल. अगर आपको पूछें कि भाई कौन सी एंटीसाइकोटिक है जो एंटी सुसाइडल, क्लोजापिन मोस्ट कॉमन कॉज ऑफ व्हाट? इट्स अ मोस्ट कॉमन कॉज ऑफ व्हाट? मेटाबॉलिक सिंड्रोम. Metabolic, most common cause of metabolic syndrome. Okay, aripiprazole, the partial dopamine agonist. ये याद रखना. अभी एक नई और एंटीसाइकोटिक है कैरिप्राजिन, दैट इज ऑल्सो पार्शियल dopamine agonist. Aripiprazole and ziprasidone are the 2 antipsychotics which having a least cause of metabolic syndrome. So you can say least cause of metabolic syndrome or least weight gain. Okay, quetiapine causes cataract, chlorpromazine having a photosensitivity. ये पॉइंट आपको याद रखना. ओके, somebody is asking about the types of delusion. Dr. Dipanshu is asking, so what we can do that just I am going, so delusion of persecution, somebody wants to harm me, somebody wants to harming, or somebody wants to kill me. Delusion of persecution, delusion of grandiosity. Okay, grandiosity, that patient thinks that he is like very special, he is having a big connection, he is a rich person. Grandiosity. Okay, then person having a delusion of love, or we call it a what? Erotomania, or we call it a Claremont syndrome. Delusion of love, the person thinks that somebody is in love with me, not I am in love, she is in love or he is in love. Okay, सर सलमान खान मुझे प्यार करता है, मैं नहीं, बट वो मुझे प्यार करता है. So this is what डिल्यूजन ऑफ लव, इरोटोमेनिया और डिक्लेरेंबोल्ट सिंड्रोम। एक होता है कोटार्ड सिंड्रोम, ये पूछा जाता है, कोटार्ड सिंड्रोम और डिल्यूजन ऑफ निहिलिज्म। Nothing exists, it is in a severe depression. We have in a severe depression, nothing exists. Patient start thinking that his or her physiological functions are not working properly. This is Cotard syndrome. Sir, I am not able to take food. Why? My intestine is not working. I am not able to talk to you. My, the mind is not working. So sometime examiner will use the word rotten. The intestine got rotten, कि intestine सड़ गई है, the internal, the organs. Patient ऐसे word use करता है because of severity of depressive symptom. Okay, delusion of infidelity. Okay, और हम इसको क्या कहते हैं, ओथेलो। Patient will think that his or her partner is not faithful to him or her. Delusion of infidelity और ओथेलो सिंड्रोम, कि सर मेरा पार्टनर मुझे चीट करता है। दे ऑलवेज गो बिहाइंड द पार्टनर, दे चेक देयर बिलोंगिंग्स। वो ऑफिस तक जाते हैं, कई बार ऑफिस के आसपास खड़े रहते हैं कि मेरा पार्टनर किससे मिलेगा या मिलेगी। दिस काइंड ऑफ डिल्यूशन। ओके गाइज, बस एक ध्यान रखना, एक मैं और बता देता हूँ, बाकी इंपॉर्टेंट हमने कर लिए हैं डॉक्टर दीपांशु। डिल्यूजन ऑफ इन्फेस्टेशन, और हम इसको बोलते हैं डिल्यूजनल पैरासाइटोसिस। पेशेंट को लगता है कि सम इंसेक्ट इन माय बॉडी, ओके, समथिंग इज इन माय बॉडी, दैट इज इन्फेस्टेशन, डिल्यूजनल पैरासाइटोसिस। और हम इसमें क्या होता है, मैच बॉक्स साइन, मैच बॉक्स डिल्यूजनल, इसको एकबॉम सिंड्रोम भी बोलते हैं। ये याद रख, मैच बॉक्स साइन। Usually signs we have in medicine, in pathology, but sometime if they can ask you the some sign, then you have to be very careful that matchbox sign seen in delusional parasitosis or delusion of infestation. Clear guys? Okay. The next is the question number 2. Answer is what? Person will have the question number 3, the young age is not the correct answer. Number 4, the premature ejaculation is seen in which phase of normal sexual cycle. ये बार बार MCQ पूछा जाता है, so ये आपको ध्यान रखना है कि what are the phases we have initially person will have desire. So what are the phases of normal sexual cycle? Desire. Second person will have what? Excitement. Third we have what? Ejaculation. Fourth we have resolution. Okay, desire, excitement, ejaculation, resolution. These are the 4 phases of normal sexual cycle. ये आपको ध्यान रखना है। डिजायर जो है, इसमें अगर आपसे पूछें कि कौन सा डिसऑर्डर होता है इन डिजायर, वी हैव, so in desire we have disorder hypoactive sexual arousal disorder. Patient have lack of desire, so hypoactive sexual arousal disorder. Okay, in desire. The second we have एक्साइटमेंट में इंपॉर्टेंट डिसऑर्डर कौन सा होता है गाइज? प्लीज रिमेंबर व्हाट? इरेक्टाइल डिसफंक्शन, बार बार पूछा जाता है इन एक्साइटमेंट, इरेक्टाइल डिसफंक्शन। ओके, द इंपॉर्टेंट वन। द ejaculation, the important one we have what? प्रीमेच्योर इजैकुलेशन, ये आपको याद है, प्रीमेच्योर इजैकुलेशन, ठीक है। या बिफोर इट वाज नॉट डिफाइंड, पहले डेफिनेशन इतनी डिफाइंड नहीं थी कि प्रीमेच्योर इजैकुलेशन बोलेंगे कब। DSM 5 ने बोला है कि इट इज लेस देन 1 मिनट, इवन द विद इन 1 मिनट और लेस देन 1 मिनट पर्सन हैविंग अ इजैकुलेशन, उसको हम क्या बोलते हैं, प्रीमेच्योर इजैकुलेशन। तो प्रीमेच्योर इजैकुलेशन इज अ फेज ऑफ व्हाट, इजैकुलेशन। इसमें अगर आपसे पूछा जाए क्या क्या ट्रीटमेंट है, ट्रीटमेंट हम देते हैं पैरोक्सिटिन। पैरोक्सिटिन एक SSRI है, बट इसका जो साइड इफेक्ट है डिलेड इजैकुलेशन, वो हम एज ए इफेक्ट यूज करते हैं इन प्रीमेच्योर इजैकुलेशन। ओके, प्रीमेच्योर इजैकुलेशन डन। ओके, so this is paroxetine. Then depoxetine. Depoxetine is also you started using as an antidepressant, but because of short half life it was not a very perfect drug for the antidepressant, and we started using as a medication for the premature ejaculation. Okay, and आपसे ये भी अगर वो पूछें, आपने पढ़ा होगा, we have a squeeze technique and sunset focus. स्क्वीज टेक्निक हम किस में यूज़ करते हैं, इन अ ट्रीटमेंट ऑफ प्रीमेच्योर इजैकुलेशन। सनसेट फोकस वी यूज इन अ इरेक्टाइल डिस्फंक्शन। दिस इज अ मास्टर एंड जॉनसन थेरेपी, हम बोलते हैं मास्टर एंड जॉनसन थेरेपी, इट्स अ कपल थेरेपी। सो स्क्वीज टेक्निक वी यूज इन अ प्रीमेच्योर इजैकुलेशन एंड सनसेट फोकस वी यूज इन अ इरेक्टाइल डिस्फंक्शन। ओके गाइस, या so this is about the ejaculation, or we can say orgasm, ejaculation or the orgasm phase. Okay, in this we have this, so orgasm phase, so answer will be what, C, orgasm phase, correct. Okay, next is confusion assessment test is used in, and answer will be, try to give the answer. Yes, confusion assessment test we use in, answer will be A, B, C, D. Guys, try. Okay, so the answer will be, okay, D, confusion assessment test. Dr. Dipanshu, we use, no guys, we don't use in dementia, we use in delirium. Confusion assessment scale, confusion assessment scale or confusion assessment test we use in delirium, okay. delirium का आप याद रखना प्लीज, that in delirium the most common organic disorder, इसके सिम्टम्स क्या क्या होते हैं, the symptoms of delirium, the most important symptom, impairment of consciousness, clouding of consciousness, cardinal feature. Because of impairment of consciousness, person will have what, disorientation to time, place and person. ये याद रखना, डिसओरिएंटेशन सबसे पहले किसका होता है, टाइम का, फिर प्लेस का, फिर पर्सन का। और रीओरिएंटेशन कैसे होता है, रीओरिएंटेशन अकर अपोजिट, इनिशियली फॉर पर्सन, देन द प्लेस, देन द टाइम, दैट सो द डिसओरिएंटेशन टाइम प्लेस पर्सन, रीओरिएंटेशन पर्सन प्लेस टाइम, एंड बिकॉज ऑफ दैट द disorientation there will be what, memory deficit, memory deficit. And because of memory deficit, in memory deficit, the deficit of what? Immediate and recent memory. The remote memory what? Remain intact. So immediate and recent memory remain, the get deficit, remote memory remain intact. There is a sleep-wake cycle, you know that disturbance, sleep-wake cycle disturbance is there. There is a sundowning phenomena. Sometimes they can ask sundowning phenomenon. In morning and afternoon patient remain better. जैसे evening होती है patient get what worsen. So this is what sundowning phenomena. In morning and afternoon person remain better. As the evening comes, as the sun set, sundowns, person symptomatology get worsen. This is sundowning phenomena seen in delirium. Okay. और एक word और याद रखना यहाँ पे क्या होता है? फ्लोसिलेशन. वो कई बार पूछा जाता है. फ्लोसिलेशन क्या होता है? पिकिंग बिहेवियर. पिकिंग behavior means person try to, suppose he is lying down on a bed और वो अपने suppose blanket पे कंबल में से कुछ ऐसे करता रहता है जैसे कि कुछ पिक कर रहा. फ्लोसिलेशन भी वो पूछ लेते हैं. ठीक है, ये आपको ध्यान रखना है. कॉजेज क्या क्या होते हैं डिलीरियम के? कॉजेज वी हैव अ इंट्रा दैट cranial cause and extracranial cause. Intracranial matlab brain related, some vascular, some infections, okay, the meningitis, encephalitis, the vascular subdural hematoma, okay, tumor, epilepsy. These can be the causes of intracranial cause. Extracranial, suppose the cardiac cause, respiratory cause, there is a hypoxia, there is a the respiratory distress, and because of that we have respiratory failure, the cardiac failure, we have some other liver issues, metabolic abnormality, sodium, potassium, one of the common cause, serum electrolyte imbalance, and sometimes polypharmacy, multiple drugs, especially in elderly patients, the multiple drugs we are giving, and that can cause of delirium. Okay, yes. आपको इसमें इंपॉर्टेंट क्या ध्यान रखना है अगर वो पूछें कि भाई ट्रीटमेंट क्या होता है? ट्रीटमेंट नंबर 1, treat the cause, treat the etiology, if there is a renal failure, you target the renal failure. If there is a electrolyte imbalance, you target the electrolyte. So whatever the cause, you have to target the cause, you have to treat the etiology. Okay guys, we give low dose of antipsychotic. Why we give low dose of antipsychotic? Please remember, to decrease psychomotor antipsychotic is nothing to do with the delirium. The treatment of delirium is what? Treat the cause, treat the etiology. Low dose of antipsychotic we give just to decrease psychomotor activity. Okay, and please remember what? Benzodiazepines. Can we give benzodiazepines in delirium? Yes or no? Please write fatafat whether we can give the benzodiazepines in the delirium or not. Guys, what do you say? Benzodiazepines are yes or no? Vikas, Jaydeep, please tell. Benzodiazepines are contraindicated. Okay. All delirium patient benzodiazepines are contraindicated except, जैसे अभी मैंने आपको बताया था, alcohol withdrawal delirium and benzodiazepine withdrawal delirium. In both delirium we give long acting benzodiazepine. We give long acting benzodiazepines. Otherwise benzodiazepines are contraindicated. Okay, for a normal, yeah. Okay, so this is the long acting alcohol withdrawal delirium and benzodiazepine withdrawal delirium. Done. Okay, so this is about the delirium. Confusion assessment test is used in delirium. Next is, which of the following has a poor prognosis with exposure and response prevention in OCD? Magical thinking, pathological doubt, hoarding, and contamination obsession. Contamination obsession. Okay, done. Correct. Magical thinking, pathological doubt, hoarding, and contamination obsession. What will be the answer? We have a new, in DSM-5 and ICD-11. In DSM-5 and ICD-11, we have, before the OCD, obsessive compulsive disorder, we were yeah, okay. OCD we were describing under the anxiety disorder, and now we basically having a separate category, that is what? Obsessive compulsive and related disorder. Obsessive compulsive and related disorder. In this we have OCD, okay, we have hoarding disorder, we have body dysmorphic disorder, okay, we have olfactory reference syndrome, okay, yeah. So OCD, hoarding disorder, body dysmorphic disorder, olfactory reference syndrome, okay, and we have the trichotillomania and excoriation disorder also we describe in this. Trichotillomania and excoriation disorder we describe. Bodily habit repetitive disorder, basically we have 5 this disorder. We have a separate category in DSM-5 and ICD-11, and we describe here. Hoarding disorder, basically person what he or she does, they basically take the unnecessary thing which is of no use, we have to discard it, but they have fear of loss, and because of that they have a habit of accumulating those things. This is the hoarding disorder. Why hoarding disorder having a poor prognosis? Because the ERP, exposure and response prevention therapy, exposure and response prevention therapy doesn't have a good response, okay, it doesn't have a good response to hoarding disorder, it has a poor prognosis. In OCD, Briefly, OCD again and again they ask obsession and compulsion. Most common type of obsession, contamination. Most common type of compulsion, checking behavior. Okay, before we had a contamination was the most common obsession, and the checking, the washing was a most common compulsion. Okay, but currently we have checking behavior is a most common type of compulsion, and most common type of obsession is contamination. Correct? If they ask you cortico striato थैलेमो कॉर्टिकल ट्रैक्ट, ये याद रखना. ओके, कॉर्टिको स्ट्राइटो थैलेमो कॉर्टिकल ट्रैक्ट, ये पाथवे है जो इन्वॉल्व होता है. एंड वी हैव अ व्हाट, सेरोटोनिन डिसरेगुलेशन in this pathway in OCD patient. Okay, in this OCD patient. Then एक याद रखना, पांडास, pediatric autoimmune neuropsychiatric disorder associated with streptococci. Pediatric autoimmune neuropsychiatric disorder associated with beta hemolytic streptococci. So जिन बच्चों को थ्रोट इन्फेक्शन स्ट्रेप्टोकोकाई से ज़्यादा होता है बचपन में, they have, there is an autoimmune response to basal ganglia, and that's why they can ask autoimmune response to basal ganglia. Autoimmune response to basal ganglia. Okay, done. Okay, so I'm writing little, I'm writing little fast. Yeah. I can write little, but this is a like sprint session. If I will write slowly guys, we can miss something. So pandas is it's a pediatric autoimmune neuropsychiatric disorder associated with streptococci. It's an autoimmune response to basal ganglia. Okay, if they ask you treatment, please remember that if they ask treatment of choice, ERP, exposure response prevention therapy, or they sometime will use the word CBT. Drug of choice is fluvoxamine. Okay, and if they ask the best modality of treatment, then your answer will be combination of both, ERP or the CBT, plus sometimes they say SSRI, sometimes they say fluvoxamine, sometimes they say, yeah, correct, true Kishore. So this is the ERP or CBT and SSRI. Done. Okay, about excoriation is the trichotillomania is what? It's a hair picking. Okay, trichotillomania. And excoriation is what? Skin picking. Olfactory reference syndrome, person को लगेगा कि that is emitting some foul odor from his body. Okay, कुछ अजीब सी स्मेल आ रही है, emitting some foul odor from his or her body. Olfactory reference syndrome, ये ध्यान रखना. Olfactory reference syndrome is described only in ICD-11 guys. It's a very important point. Okay, yeah, correct. So pulling hair is a trichotillomania, that picking, the, and the excoriation is a skin. And olfactory reference syndrome is a person emitting some feels, he thinks that's emitting some foul odor from his or her body. Correct? This is olfactory reference syndrome. So this is a separate category we have in ICD 11 and DSM 5. Done? Okay. So question number 6, answer is what? Hoarding. Hoarding. Fear of height is known as, please give the answer. Fear of height known is, answer is fatafat. It's a acrophobia. Very true. Yes, Satu. Acrophobia. Yeah. Acrophobia. So sometimes they can ask that there is a nyctophobia, fear of, darkness. Okay. Claustrophobia, fear of closed space. Okay. Fear of sitophobia, SITO, fear of eating, the algophobia, fear of pain. Okay, fear of height already we discussed. So these sometimes that the phobias also they can ask. Okay, please remember, if any they ask the treatment of choice in any phobic disorder, answer will be behavior therapy. Behavior therapy. Any phobia. What's the difference between phobia and anxiety? Anxiety is an irrational fear and phobia is related to object. Correct? So that you have to remember. You want break or shall we continue? Yes, guys. Mix, yeah, Dipanshu, we have a agoraphobia. Agoraphobia. It's a basically mix. You can say phobia of at least two places. Phobia of at least two places. Correct? Yeah. Okay. Okay then. Okay. Next is a 30-year-old male presented with a complaint of a feeling of insect crawling under the skin. Which of the following drug abuse can cause the symptom of this patient? Alcohol, cocaine, amphetamine, and cannabis. Yes. Answer will be cocaine. Correct. The answer will be B, cocaine. Cocaine is a what? CNS stimulant. The CNS stimulant. It basically increase serotonin and norepinephrine. The CNS stimulant increases the serotonin and norepinephrine. Done? We use cocaine in various ways. We can snort, we can smoke, we can use IV. Okay, so there are various way to use cocaine. Cocaine causes what? Nasal septum perforation. Nasal septum perforation. In intoxication of cocaine, patient can have that euphoric effect. Patient can have sweating, palpitation, okay, sleep disturbance. Just remember that cocaine can cause cocaine induced psychosis. Cocaine induced psychosis. The important point here, guys, that it's a reverse phenomenon. It's a reverse, reverse phenomenon. Reverse phenomenon. Like when you stop the cocaine in a withdrawal symptom, you can have this cocaine induced psychosis. Cocaine induced psychosis. Okay, it's a reverse phenomenon that you have to remember. Okay, there is a cocaine induced psychosis. We have delusion of persecution and tactile hallucination. We have paranoid delusion, and tactile hallucination. Tactile, correct? Tactile hallucination. Yeah. Yes, this is a tactile hallucination. The another name of tactile hallucination is what? We call it a cocaine bugs. We call it a Magnan symptom, and we call it a formication. The different name of a same phenomena: tactile hallucination, cocaine bugs, Magnan symptom, and formication. Okay, yeah. That you have to remember. Amphetamine, just remember one thing: amphetamine can cause paranoid schizophrenia like syndrome. Amphetamine can cause paranoid schizophrenia like syndrome. Paranoid schizophrenia like syndrome. Okay. A 40-year-old male who lost his wife 3 months back complained that his intestine have become rotten. He feels that he is responsible for his wife's death, should be sent to prison. He complains of feeling low all the time and has lost interest in daily activity since his wife's death. What is the most likely diagnosis? So, it's a delusional disorder, it's a psychotic depression, it's a normal grief reaction, it's a schizophrenia. Guys, please tell me, what's the answer? Answer will be okay. Yes, please. Answer will be okay. Okay. Delusional disorder. As Atul. Okay. No, not no. Okay. The answer will be, see. Just see. You just don't jump into the conclusion. Just see the MCQ language. Person having a feeling low all the time, has lot interest in daily activities, wife death, and then he started talking about, just few minutes before I mentioned that what's a Cotard syndrome or delusion of nihilism. Person having a the thinking that his or her physiological functions are not working properly, intestine have become rotten. So it's a, you can say, psychotic depression or severe depression with psychotic symptom. Okay, so just briefly, how we make a diagnosis of depression in DSM-5. How we make a diagnosis of depression? There are 9 criteria. The sadness of mood, diminished interest in pleasurable activities. There are negative thoughts, sleep disturbance, decreased appetite, decreased libido. Okay, 9 symptoms. Out of 9, just remember 5 out of 9. This is one DSM. In 5, there are 2 initial the symptoms, like sadness of mood and decrease pleasure in activity. Okay, in activity. This out 9 symptom DSM mentioned that 5 out of 9 is sufficient for making a diagnosis of depression, but out of this 5, one symptom should be from initial first two. And what are the first two? Sadness of mood and decrease the pleasure or diminished pleasure in activities which were pleasurable previously, like kind of anhedonia. Okay, yeah. In ICD we have mild depression, we have moderate depression, and we have a severe depression. Okay, mild depression is what? 2 plus 2, 2 major criteria and 2 minor criteria. Moderate is 2 plus 3, 2 major and 3 minor, and severe is 3 plus 4, 3 major and 4 minor criteria. Okay, so 2 plus 2 mild, 2 plus 3 moderate, and 3 plus 4 severe. Moderate depression we divide in two parts, with somatic syndrome and without somatic syndrome. With somatic syndrome and without somatic syndrome. Okay, somatic syndrome is what? When the examiner mention in MCQ early morning awakening, kitna early? At least 2 hours early. Okay, depression more worse in the morning, psychomotor retardation, psychomotor agitation. अगर ऐसे word examiner use करता है, इसका मतलब it's a moderate depression with somatic syndrome. So somatic syndrome shows the severity. Okay, once the severe depression we have, it means that we assume that somatic syndrome is there. Severe depression we mention with psychotic symptom and without psychotic symptom. In severe depression we have either with psychotic symptom or without psychotic, with psychotic symptom and without psychotic symptom. Clear? Okay guys, just remember ICD 11, only one thing. ICD 11 mention that psychotic symptoms we have in severe depression, but psychotic symptom also can be part of moderate depression. That you have to remember. So before we were saying that one psychotic symptom in a picture along with depressive symptom, always diagnosis was severe depression with psychotic symptom. But ICD 11 mention करती है कि usually we have psychotic symptoms in the severe depression, but psychotic symptoms also can be a part of moderate depression. So अब ये ध्यान रखना, एक नया change in ICD 11 that psychotic symptom we can have in a moderate depression as well. Okay, yeah. मूड डिसऑर्डर में आपको क्या क्या ध्यान रखना है? ICD 11 में क्या क्या चेंजेस आए गाइस? ये इंपॉर्टेंट एरिया है जो वो पूछ सकते हैं. ओके, ICD 11 में क्या क्या चेंज है? एंड इन योर DSM 5 प्लीज रिमेंबर, वन इज व्हाट? डिसरप्टिव मूड डिसरेगुलेशन डिसऑर्डर. ये एक नया डायग्नोस्टिक क्राइटेरिया है, DMDD. ये समटाइम वो पूरा आपको पूरा लिखते भी नहीं है, DMDD दे देते हैं, डिसरप्टिव मूड डिसरेगुलेशन डिसऑर्डर. एंड सेकेंड इज व्हाट? PMDD, प्री मेंस्ट्रुअल डिस्फोरिक premenstrual dysphoric disorder. So disruptive mood dysregulation disorder and premenstrual dysphoric disorder, PMDD. These are the two new category we have in a DSM 5 and ICD 11. ज़्यादा हम इसकी डिटेल में बात नहीं करेंगे, बट रिमेंबर वन थिंग, डिसरप्टिव मूड डिसरेगुलेशन डिसऑर्डर की पिक्चर क्यों आई? वाई वी ब्रॉट दिस? बिकॉज इट हैज़ बीन सीन कि भाई जो बच्चों में we were somehow I think over diagnosing the bipolar disorder. तो जो बाइपोलर डिसऑर्डर के हम ज़्यादा डायग्नोस करते थे बच्चों में, बट बाद में देखा जाता था कि उनमें है ही नहीं बाइपोलर डिसऑर्डर। तो देखा गया कि उनमें जो इरिटेबिलिटी है, एंगर आउटबर्स्ट है, जो टेम्पर आउटबर्स्ट है, उसके लिए नया डायग्नोसिस दिया गया, डिसरप्टिव मूड डिसरेगुलेशन डिसऑर्डर की बच्चे में। इसमें टेम्पर आउटबर्स्ट है विच इज़ आउट ऑफ प्रपोर्शन। कितना होना चाहिए? एटलीस्ट थ्राइस इन अ वीक। कितने दिन के लिए होना चाहिए? 12 मंथ्स, 12 महीने के लिए। सो 2-3 पॉइंट याद रखना, कितनी बार होनी चाहिए वो इरिटेबिलिटी, टेम्पर आउटबर्स्ट? 3 टाइम्स पर वीक एंड एटलीस्ट व्हाट 12 मंथ्स। एंड एक पॉइंट बस और याद रख लेना, एज कितनी होनी चाहिए? 6 to 18, मोर देन 16 एंड लेस देन 18। 6 साल से कम नहीं होना चाहिए एंड 18 ईयर से ज़्यादा नहीं होना चाहिए, तब हम डिसरप्टिव मूड डिसरेगुलेशन डिसऑर्डर बनाते हैं। इसमें ट्रीटमेंट याद रखना, एग्जाम में पूछा जाता है क्या भाई, इसमें क्या देते हैं? साइकोथेरेपी प्लस एंटी antipsychotic. Sometimes we can use the stimulants, and sometimes if there is some low feeling or antidepressant, but role of antidepressant is minimum, mainly psychotherapy and antipsychotic. काम की बात, there is no use of mood stabilizer, in DMDT. ये पॉइंट याद रखना, ये पूछा जाता है, नो mood stabilizer. Okay, no lithium, no valproate, no mood stabilizer. Correct? Premenstrual dysphoric disorder, yes, before one week before, prior to onset of menses and few days after onset of it, we have a this depressive symptom. So इसका over the years से देखा गया कि ये काफ़ी पेशेंट ओपीडीज में आती थी ड्यूरिंग मेंस्ट्रुअल साइकिल, एंड ये नई सेपरेट कैटेगरी दे दी गई, PMDD, प्रीमेंस्ट्रुअल डिस्फोरिक डिसऑर्डर। ड्रग ऑफ चॉइस इज व्हाट? SSRI। ओके, ये आपको ICD-11 और DSM-5 में ध्यान रखना है। और एक और ध्यान रखना कि जो डिस्थाइमिया है, डिस्थाइमिया आपको पता है इट्स अ मूड डिसऑर्डर। डिस्थाइमिया का नया नाम क्या दे दिया गया? परसिस्टेंट डिप्रेसिव डिप्रेसिव, करेक्ट? persistent depressive 2 years subthreshold depressive symptom and we making a diagnosis of dysthymia. ड्यूरेशन कितनी चाहिए? एडल्ट के लिए 2 years एंड चाइल्ड के लिए 1 year. Okay, done? Okay guys, are you enjoying? Are you there? Okay, okay, so we are talking the question number 9, the B for Bombay, psychotic treatment of choice for postpartum blues, fluoxetine, cognitive behavior therapy, lithium carbonate, and support and education. Yes, please tell what will be the answer. Treatment of choice for postpartum blues. तो ये बार बार पूछा जाता है एग्जाम में, इसको मैं आपको थोड़ा सा क्लियर करवा देता हूँ। पोस्टपार्टम ब्लूज, देखो ये मूड डिसऑर्डर है रिलेटेड टू प्रेगनेंसी एंड डिलीवरी। इसमें एक पूछते हैं वो पोस्टपार्टम ब्लूज, एक पूछते हैं पोस्टपार्टम डिप्रेशन, एक पूछते हैं पोस्टपार्टम साइकोसिस। ओके, तो पोस्टपार्टम ब्लूज, पोस्टपार्टम डिप्रेशन एंड पोस्टपार्टम साइकोसिस। डन? पोस्टपार्टम ब्लूज onset we have in 2 to 5 days. So onset is 2 to 5 days. Postpartum blues, onset is 2 to 5 days. After delivery, within 5 days, usually the person has the female will have these symptoms. Symptom क्या क्या होंगे? What will be the symptom? Irritability, okay, sleep disturbance, mood lability. So mood lability, irritability and sleep disturbance. Postpartum blues. Treatment, basically, usually what happens, the resolution of this symptom will subside like within 2 to 3 weeks. So usually we don't have any particular treatment for this, just support to the mother, educate the mother. Okay, so in this answer will be D for daily, support or educate the mother. Postpartum blues. Postpartum depression, it will start within like 2 to 5 days. Okay, it starts postpartum depression around 2 weeks. Always you will get the history or what after 2 weeks. Okay, after 2 weeks, but within 1 month you will get the history of within 1 month. Postpartum psychosis also, like you will get the history around or after 2 weeks, and it is also within 1 month. Postpartum depression, the female will have proper depressive symptom, and along with the depressive symptom she can have the ideas to harm herself or ideas to harm the child. So there can be a suicidal tendency. Okay, so usually we give SSRI medication. If suicidal tendencies are there, then we give ECT. So there will be proper depressive symptom, and along with that the ideas of thoughts of harming herself or harming child. If the suicidal tendencies are there, these ideas are there, then we go for ECT. And the postpartum psychosis, the female will have the psychotic symptom. Okay, हो सकता है वो बोलने लग जाए कि मैंने बच्चे को जन्म ही नहीं दिया, आई डिड नॉट गिव बर्थ टू द चाइल्ड, बच्चे को हार्म करने की कोशिश करती है. यू हैव टू बी वेरी केयरफुल. एंड उसमें पोस्टपार्टम साइकोसिस में ट्रीटमेंट हम क्या देते हैं? एंटी साइकोटिक. तो आपको क्या याद रखना है कि इन postpartum blues, onset 2 to 5 days usually. And remember one more thing, that if they ask you how many, roughly like 30 to 75% female have this postpartum blues, 10 to 15% female have postpartum depression. ये भी पूछा जा सके. Okay, so postpartum blues roughly 30 to 75, postpartum depression 10 to 15%. Okay, postpartum depression and postpartum psychosis, we give the treatment antipsychotic. Okay guys, can we have 15 minutes break and then we'll go further? Okay, so 15 minutes break. Done. Okay guys, so shall we start? Somebody is writing I am not able to concept that, this class we, how we can make for the concept. We have to be, it's a revision class here students, so concept we have to make before revision. According to revision class also, I think I am giving little more, otherwise you will not able to complete the whole important topics anyway. Okay, so this is the important one: postpartum blues, treatment of choice, support and education. Next question guys. As 26-year-old woman complain of a crawling sensation in her leg. It is more at night and prevents her from sleeping. She is relieved of these symptoms by either walking or moving her legs. Which drug is used for the treating this condition? Pramipexole, iron tablet, vitamin B12, gabapentin. Please tell. Atul is asking. Okay, I'll do that. Pramipexole, iron tablet. ECT, no, Atul, we are giving ECT. No, it's not banned. It's a okay. ECT will come in a mental health care act bill. There I will tell you. ECT is not banned yet, but yes, in minor we can't give the ECT. Okay. Now people don't usually prefer, but if we can say it is banned, no, it is not banned. Okay. In this question guys, the diagnosis is what? The diagnosis is restless leg syndrome. Restless leg syndrome. Okay. In restless leg syndrome, the person is what? Especially the during the evening time, he or she will have a restlessness in the legs, and when the person move around, जब इधर उधर घूमता है तो पेशेंट को थोड़ा रिलीफ फील होता है. दिस इज रेस्टलेस लेग सिंड्रोम. इसमें हम ट्रीटमेंट क्या देते हैं? ट्रीटमेंट आपको ध्यान रखना है. वी गिव व्हाट? डोपामिन एगोनिस्ट. वी गिव डोपामिन एगोनिस्ट. डोपामिन एगोनिस्ट. Pramipexole and ropinirole. And one is already written here, pramipexole. Pramipexole and ropin. Clear? Yeah, restless leg syndrome. Correct. Okay. Restless leg syndrome, and the disorder we described that. Okay, there is a REM sleep disorder and an REM sleep disorder, and another we have a two type of disorder we describe. One is two type of sleep disorder. Another classification we have insomnia, and we have parasomnia. In dysomnia, further we divide insomnia and hypersomnia. In insomnia, we have these, various psychiatric disorder, depression, schizophrenia, insomnia, and we have what? Restless leg syndrome. Okay, and we have periodic limb movement disorder. Okay, the restless leg syndrome and periodic limb movement disorder. Restless leg syndrome, we give what? Dopamine agonist, ropinirole and pramipexole. Periodic limb movement disorder, we give clonazepam. That you have to please remember. Benzodiazepine, clonazepam. Intermittent jerky movement a person will have. Hypersomnia, you know that we have already narcolepsy I described in detail, and we have Klein-Levin syndrome. Okay, hypersomnia, hyperphagia, okay, hypersexuality. This is the hypersomnia. So we have a dysomnia, in dysomnia, insomnia, and hypersomnia, and we have parasomnia. We have parasomnia. Okay, guys. In parasomnia basically the dysomnia is a sleep disorders. Parasomnia we can say behavior, related to sleep. So parasomnia basically all NREM sleep disorder, they come under parasomnia. All NREM sleep disorder, correct? They come under parasomnia. That you have to remember. Clear? Yeah. Next is, so this is the answer will be pramipexole. A 25-year student came to OPD with intermittent episode of feeling of impending doom accompanied by intense perspiration. Usually the episodes occur prior to her exam. What is the most likely diagnosis? Panic disorder, conversion disorder, social anxiety disorder, generalized anxiety disorder. What will be your answer, guys? Answer will be panic disorder. So what is panic attack? We have in panic attack, it's a what? It's an acute onset. Always acute onset. Patient present with what? Somatic symptoms like dryness of mouth, respiratory difficulty, or person will say choking sensation, increased heartbeat or palpitation, acidity, the restlessness in the body, muscle tension. Okay, and person feel that today I'm going to die, today is my last day, feeling of impending doom. This is the panic attack. Usually peak in like 10-15 minutes. Okay, peak goes in 10-15 minutes, and then person gradually anxiety decreases. This is like one episode of panic attack, and after end of the panic attack, the person will feel like energy less, the energy got drained. This is the panic attack. Okay, whenever the patient come to you with the panic attack, we always rule out what? Organic disorder, because first diagnosis is never a psychiatric diagnosis. So what are the organic causes of panic attacks? Sometimes they can ask that what are the organic causes of panic attack. आपको ध्यान रखना है. This is what number 1 is hypothyroidism. Hyperthyroidism. Okay, hyperthyroidism. Person can have arrhythmia. Okay, carcinoid syndrome, epilepsy, hypoglycemia. So hyperthyroidism, arrhythmia, carcinoid syndrome, epilepsy, hypoglycemia, mitral valve prolapse. Mitral valve prolapse. Okay, either they will give you, these are the sometimes they will give you the direct organic causes, sometimes they will give you that you are person presented to the emergency with a panic attack, what all investigations you would like to do, except. So in this hyperthyroidism, what we will do, thyroid profile. So you have to do the thyroid profile. Arrhythmia, what you have to do? ECG. In epilepsy, what you have to do? EEG. Okay. In hypoglycemia, what you have to do? The blood sugar level. The they will mention the directly uh, organic causes, or they will mention the investigations, and usually they give the thyroid profile, ECG, blood sugar level, and they will give the complete hemogram. Complete hemogram is nothing to do with the panic attack. We have at least 4 panic attacks in 1 month, then we call it a panic disorder. 4 panic attacks in 1 month, then we call it a panic disorder. And the treatment of any panic disorder, the treatment of choice is what? The treatment of choice in panic disorder is, treatment of choice we have CBT. Treatment of choice is CBT. Yeah. And the medication we use, yes, SSRI, and we use buspirone. That you have to remember. We have bupropion. Bupropion is a antidepressant, norepinephrine dopamine reuptake inhibitor, and we have buspirone. Buspirone is a 5-HT1A partial agonist. That you have to remember. Okay, it's we use as a anti-anxiety drug, 5-HT1A partial agonist. Okay, yeah. So the treatment of choice, cognitive behavior therapy, the drugs, SSRI, buspirone. But if they ask what is the best modality of treatment, then it's a combination of medicine plus SSRI plus SSRI. Okay. Okay, guys. So next is, so this is panic disorder. Generalized anxiety disorder, it's a, like we have a in generalized anxiety disorder, another anxiety disorder. In this we have a 2 important major criteria: unnecessary worries, and person is not able to control that worries, and because of that we have a 6 minor criteria, like restlessness, irritability, muscle tension, sleep disturbance, easy fatigability, decreased attention and concentration. These are the 6 minor and 2 major. We make a diagnosis at least 2 major and 3 minor. For at least 6 months we make a diagnosis of generalized anxiety disorder. Okay, generalized anxiety disorder. Free floating anxiety, basically in generalized anxiety in every domain, free floating. What is the maximum period of voluntary self admission under the Mental Health Care Act? The Mental Health Care Act, you have to remember that this is an area where they can ask questions. And because before we were calling it a Mental Health Act, in 1987 it came, and now that we made some changes in this, and now currently we call it a Mental Health Care Act bill. So this bill actually tells us how to admit the patient, for how many days we can admit, what do, what not to do. These are the basically they can ask. So maximum period of voluntary self admission in mental care health bill is a 30 days. That you have to remember, number one. In Mental Health Care Act bill, few the words you should know, that what are the some phrases you should know. One is advance directive. Advance directive. Okay. In advance directives, person can decide how to be treated and how not to be treated. So person has to decide. Every person make a advanced directive, that how he should be treated or should not to be treated, not to be. Okay, number one, advanced directive. Person has a this this is a new, we give in a Mental Health Care Act bill. We have to ask the patient. Number two, the representative, basically the nominated representative. Nominated representative Nominated representative, the patient decide that who will take a, the person can be appoint a nominative for him or for her, that they can appoint a nominative, that if the patient lost capacity to decide about his or her treatment. If the patient lost capacity to decide about his or her treatment, then they can use nominative representative. It's the patient can appoint. But advanced directive is more important than the nominated representative. Nominated representative only we have to use in a case when the person lost the capacity to decide about treatment. Okay, that you have to remember. Okay, admission, I told you one MCQ they can ask. Suppose if they ask, you have to be very careful that what is Spike's protocol. Spike's protocol is what? How to reveal the bad news. आप पेशेंट को HIV है, पेशेंट को कैंसर है, हाउ टू रिवील द बैड न्यूज, तो वो आप कैसे करते हो? स्पाइक्स प्रोटोकॉल के थ्रू। ये बस आपको याद रखना। एज फॉर सेटिंग इंटरव्यू, आप इंटरव्यू सेट करते हो। ओके, नंबर 2, P for you assess the perception of patient. You assess the perception of the patient. I is what you do, you basically obtaining the patient invitation कि पेशेंट आपसे पूछना चाहता है नहीं पूछना। तो आपने इंटरव्यू सेट कर लिया, आपने पेशेंट का परसेप्शन जान लिया कि भाई क्या कितना जानता है नहीं जानता, इन्विटेशन पेशेंट पूछना चाहता है या नहीं पूछना चाहता है। ओके, एंड देन K for you give the knowledge about the diagnosis, about the treatment, about the the future consequences, prognosis. You have to do that. Okay, and then if the patient become emotional, after knowing it, you address the emotions of the patient. Okay, emotions of the patient, you basically address it, and then you make a basically strategy thereafter. तो ये स्पाइक्स प्रोटोकॉल आपसे पूछा जा सकता है, बी वेरी केयरफुल अबाउट इट. So again I am repeating, to reveal the bad news we use the spikes protocol. As for setting interview, P for perception, I for obtaining the invitation of the patient, that whether he wants to know how much he wants to know. A, that giving the knowledge about the treatment, diagnosis and prognosis. E is what we, after revealing it, we address the emotion of the patient and then we make a strategy. S, spikes protocol. ये आपको याद रखना, ये एक MCQ पूछा जा सकता है. Okay, and advanced directive, nominated representative, admission, ये this is very very important. Okay, done. Okay, I will do that. Clear? Okay, okay. Namaste Pushpanda. Okay, okay, so what is the maximum period? 30 days. Next question is identify the stage of sleep based on easy finding. I already told you that in this red wala thing, it's a basically I mentioned that as from alpha, beta, gamma, alpha, beta, theta and delta, we go from REM to NREM. Okay, and because of that we have this in this red wala option, basically the frequency is very high and the voltage, the amplitude is low, so it will be REM sleep. ये आपको ध्यान रखना. We'll come to that again. So in this the answer will be REM sleep. Okay. Done. Next is a 30-year female present with the history of loss of interest in a day-to-day activities, weight loss, insomnia, and sadness for 6 months. She also recalls hearing a voice once that ordered her to kill herself. What's your diagnosis? DSM-5. So 30-year male present with history of depressive symptom, and then the hearing voices that order. The answer will be major depressive disorder with psychotic symptom, schizophrenia, schizoaffective disorder, delusional disorder. That answer you have to give. I'm doing Atul because there's some, somebody is asking. Clear? The answer will be, फटाफट लिखो. Atul, write please. Everybody. Manish. Answer already we discussed it. Okay. So answer will be what? Major depressive disorder with psychotic symptom. Yeah. Major depressive disorder with psychotic symptom. Already we discussed it in a detail. During psychotherapy, the therapist has mixed conscious and unconscious, feeling towards his patient. This is known as, the therapist has mixed conscious and unconscious feeling towards the patient. This is known as counter-transference, dissociation, transference, preoccupation. Yeah, correct. Okay, very good. Yeah, counter-transference. So you have to remember just two things here. One is what? The patient feeling towards doctor. This is what? Transference. This is transference. And the doctor's feeling towards the patient, it's what? Counter transference. Okay, the Freud used these words, transference and counter transference. Counter transference. Okay, yeah. Freud, just few things about Freud. He has given the, Freud has given the topographical model, and he has given structural model. Okay, in topographical model 1900 and structural model in a 1923. Topographical model he divide in conscious, pre-conscious and unconscious. Conscious, preconscious and unconscious. He told that what we can share with the world, we can share our thought with the world. दुनिया के साथ जो हम शेयर कर सकते हैं, जो हमें एंजाइटी नहीं देते, जो आइडियाज़, जो थॉट्स, उसको हम लोगों से शेयर कर सकते हैं, वो हमारे कॉन्शियस लेवल में होते हैं. जो कॉन्फ्लिक्ट्स होते हैं, जो हमें एंजाइटी देते हैं, वो किस में होते हैं? अनकॉन्शियस लेवल में होते हैं. और प्रीकॉन्शियस एक्ट एज ए बैरियर. इट एक्ट एज ए बैरियर. ओके, ये टोपोग्राफिकल मॉडल था. जो इंटरप्रिटेशन ऑफ ड्रीम एक उन्होंने बुक लिखी थी, उसमें दिया था टोपोग्राफिकल मॉडल 1900 में. स्ट्रक्चरल मॉडल उन्होंने दिया था इड, ईगो एंड सुपर ईगो. इड, ईगो एंड सुपर ईगो. Okay, so you can watch my videos soon. They are going to release, and in future classes also we'll discuss about it, guys. That id, ego, super ego, this structural model, टोपोग्राफिकल मॉडल, ये आपको ध्यान रखना है. एक बस और ध्यान रखना कि बेसिकली आपने देखा होगा समटाइम दे आस्क दैट इन अ डिसोसिएटिव डिसऑर्डर हाउ टू लाइक पर्सन इन डिसोसिएटिव डिसऑर्डर, दिस कॉन्फ्लिक्ट पर्सन अबाउट द कॉन्फ्लिक्ट्स, ही और शी इज नॉट एबल टू, दे डोंट वांट टू डिस्कस अबाउट इट. सो हम क्या यूज़ करते हैं? एक वर्ड याद रखना, ये एमसीक्यू काफ़ी पूछा जाता है. अब्रिएक्शन एंड कैथारसिस. अब्रिएक्शन और कैथारसिस, उसमें ये जो बैरियर है उसको हम हटा देते हैं प्रीकॉन्शियस वाले को अब्रिएक्शन और कैथारसिस में. एंड वो बेसिकली the person is able to tell about his or her conflict. ये भी पूछा जाता है. ओके. अब रिएक्शन और कैथारसिस, CATHAR, कैथारसिस. क्लियर? ओके गाइस. So the 16 answer is counter transference. Next is an alcohol stopped alcohol consumption for 3 days and presented with okay. दिखाई दे रहा है guys? Now it's better. An alcohol stopped alcohol consumption for 3 days and presented with irritability, disorientation, paranoid delusion, agitation, visual hallucination and altered sensorium. What is the likely diagnosis in this case? Answer will be delirium tremens, Wernicke's encephalopathy, Korsakoff psychosis, alcohol induced psychosis. So answer will be, बताओ please. छोटी और छोटे करूं? अब ठीक है? Yeah, already we discussed delirium. So after for 3 days, as I mentioned there, that table guys, please remember that alcoholic hallucinosis, alcohol withdrawal seizure and alcohol withdrawal delirium or delirium tremens. Within 24 hours alcoholic hallucinosis, between like 12 to 48 hours this is our alcohol withdrawal seizure, and the 48 to 72 hours or 2 to 5 days alcohol withdrawal delirium. That you have to remember. Person having a irritability, disorientation, delusion, hallucination, all these, the answer will be what? Delirium tremens. Answer will be A. Okay, delirium tremens. Treatment I mentioned, long acting benzodiazepine. Wernicke's encephalopathy, basically Wernicke's encephalopathy occur due to what? Occur due to thiamine deficiency. Because of thiamine deficiency, Wernicke's encephalopathy, we have global confusion, we have ophthalmoplegia, and we have ataxia. So we have in Wernicke's encephalopathy, we have 3 things: global confusion, ophthalmoplegia, and ataxia. Global confusion, ophthalmoplegia, and ataxia. ओके, करेक्ट. ये पूछा जाता है. तो इसमें एक अच्छा कॉन्सेप्ट याद रख लेना. बेसिकली थायमिन डेफिशिएंसी, उसकी वजह से कहाँ पे दिक्कत होती है? मेमोरी बॉडी एंड डोर्सोमीडियल न्यूक्लियस ऑफ थैलेमस. मेमोरी बॉडी एंड डोर्सोमीडियल न्यूक्लियस ऑफ थैलेमस. क्लियर? या. How to differentiate between delirium and the Wernicke's encephalopathy? In delirium, yes, there is a delirium. In Wernicke's encephalopathy, there will be delirium plus ophthalmoplegia, because whenever they give the MCQ, they can give the Wernicke's encephalopathy also, and they can give the delirium also. So what is the basic difference between delirium and Wernicke's encephalopathy? In delirium only the delirium picture will be there. In Wernicke's encephalopathy, delirium plus ophthalmoplegia. ये आपको याद रखना है. And another MCQ I mentioned there, in delirium tremens or alcohol withdrawal delirium. In alcohol withdrawal delirium or delirium tremens, usually after stopping alcohol, it usually occur between 2 to 5 days, maximum up to 7 days. But agar aapko suppose the examiner is saying the person is taking alcohol since 10 years, so by giving the history of 10 years, he actually giving you hint that person is alcohol dependent. Then he's saying after stopping alcohol abruptly or suddenly he started having, or he will create a picture of delirium. Okay, and he will give the duration between 2 to 5 days. Then your answer will be delirium tremens or alcohol withdrawal delirium. Suppose the same picture he is giving, all the lines are same, but in last he mentioned that this picture occurs after 10th day. Then what will be your diagnosis? I mentioned clearly that in delirium tremens or alcohol withdrawal delirium, usually it occurs like within 7 days, not after 7 days. After 7 days, if it is there, then the diagnosis is what? delirium, sorry, the vernix encephalopathy. So ये भी आप याद रख लेना that after they giving the history of alcohol, and so before 7 days and after so before 7 days it will be delirium tremens, okay, delirium tremens, and after 7 days vernix encephalopathy. ऐसे आप याद रख सकते हो. दिस इज अ गुड कॉन्सेप्ट. ओके, वर्निक्स कोर्साकॉफ साइकोसिस, इट्स अ मोर सीवियर डिसऑर्डर इवन देन द वर्निक्स एंसेफेलोपैथी. ओके, कोर्साकॉफ साइकोसिस में बस एक पॉइंट आपको याद रखना है, क्या? कॉन्फेबुलेशन. कॉन्फेबुलेशन. ओके, patient forgets about the past but patient also forgets that he forgets. okay, पेशेंट भूल जाता है लेकिन पेशेंट ये भी भूल जाता है कि वो भूल जाता है. सो व्हाट ही डज, ही बेसिकली फिलिंग अप द गैप्स बाय द फॉल्स मेमोरी. आपने पेशेंट को पास्ट के बारे में पूछा, पेशेंट भूल गया, बट पेशेंट ये भी भूल गया कि वो भूल गया, तो वो क्या करता है कि जो 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 गैप्स हैं, मेमोरी के गैप्स, वो फॉल्स मेमोरी से फिलअप करता है. उसको हम कॉन्फेबुलेशन कहते हैं, फिलिंग अप मेमोरी गैप्स बाय द फॉल्स मेमोरी, कॉन्फेबुलेशन. ओके, so this is the question number 17. Answer will be A. Question number 18. Which of the following is a formal thought disorder? Obsession, derailment, delusion, thought insertion. Yes. Stress related. Okay, stress related, guys. I can tell you, somebody is asking, so I'll tell you one thing that. Yes, in last, now the time is very nearby, so number one, don't revise, don't touch anything which is new topics you should not touch. Just as your plan is there, you just have a good planning and try to revise the basic and minor subjects more. It's a like backbone of the any exam, because basic subjects, if you know, in a major subject last time, even after knowing, sometime you can do the mistake, and even without knowing, with the common sense you can do. But if the basic, if you don't revise, then you can't do with the guess in basic and minor subjects. So basic and minor subject, revise. You can't come in one day in the competition, you can't go out from the competition in a one day, so it's a gradual process. So just hit nicely in as you know, as per your knowledge. Think what you know, but before exam, don't think too much what you don't know, because knowing is fine, but when you don't know, then okay, यार my friend को तो ये भी पता है, मुझे तो नहीं पता, and you get पता है, best of luck to him, but you just focus on your strength कि आपको क्या पता है. एंड अभी आप और 5-7 डेज अपने आप को स्ट्रेच कर सकते हो. उसके बाद में थोड़ा स्लीप पैटर्न का भी ध्यान रखो, बिकॉज एज ए साइकिट्रिस्ट आई एम टेलिंग यू, सडनली स्लीप पैटर्न, ज़्यादातर स्टूडेंट नाइट में पढ़ते हैं और फिर उस दिन नाइट में भी नहीं सो पाते, और मॉर्निंग में आपको पता है कि उस इतने कम टाइम में आपको यू हैव टू गिव योर 100%. तो उस वक्त आपको आपका जो स्लीप पैटर्न है उसको थोड़ा बेटर रखो. एंड द नॉर्मल एडवाइस इज दैट गुड फूड हैबिट्स एंड गुड स्लीप, बट येस, just revise the basic and minor subjects more, and high yield topics, because in my initial session I mentioned कि भाई आपको that they don't change the topic, they change the MCQs. so आपको high yield topics, previous years MCQs, previous years topic बार बार रिपीट होते हैं एग्जाम में, आप देखोगे मेनली वही चंक आता है, वो कभी इधर से पूछ लेते हैं, कभी उधर से पूछ लेते हैं. so that is very very important here. okay, so yeah, apart from that, if any individual, that will discuss later if you want to discuss one-to-one or something. okay, clear guys? okay, so yeah, which of the following is a formal thought disorder? Obsession we comes in under what? thought possession. ये आपको, आई होप आपने अच्छे से पढ़ रखा है मेंटल स्टेट एग्जामिनेशन. थॉट पोजीशन के अंडर क्या आता है? सो आपको ये ध्यान रखना है कि एक होता है डिल्यूजन, एक होता है hallucination, and one we have what? So delusion, hallucination, and okay, obsession. Obsession, delusion comes under thought content, thought content. Okay, hallucination come under perception, and obsession comes under thought possession. ये भी एमसीक्यू बहुत बार पूछा जाता है, ठीक है, थॉट पोजेशन। बाकी ये जो आपके फॉर्मल थॉट डिसऑर्डर होते हैं, फ्लो में, स्ट्रीम में, फॉर्म में अलग अलग आते हैं। तो जो फॉर्म आपका फॉर्मल थॉट डिसऑर्डर है, ठीक है, ओके गाइस। इल्यूजन ऑल्सो कम्स इन परसेप्शन, अतुल। इल्यूजन एंड हेल्यूसिनेशन. Hallucination is what? False perception without stimuli, and illusion, dear, is what? Misinterpretation of normal stimuli. Okay, so illusion and hallucination comes under perception. The obsession comes under thought possession, and thought possession के अंदर ये आपका obsession के अलावा और क्या आता है? Thought insertion, thought withdrawal, and thought broadcasting. Thought broadcasting, ये आप ध्यान रखना। तो thought insertion, thought withdrawal, and thought broadcasting, that also comes under thought possession. Clear? Okay, so formal thought disorder में इसमें क्या आएगा? आंसर विल बी derailment. ये ध्यान रखना। what we other thing we have under FTD, formal thought disorder में आपका derailment आता है। okay, we have tangentiality, we have circumstantiality, okay, we have thought block, okay, we have verbigeration, that completely nonsense words. So these kind of thing they will ask you. So derailment basically ये क्या है? person starts from the topic जो आपने पूछा, please tell me about daily. So starts from the topic, then he goes to the another topic, and never comes back. This is derailment. Like a railway, the train got derailed from the railway track. Derailment. टेंजेंशियलिटी और डिरेलमेंट में क्या फ़र्क होता है यार? कि टेंजेंशियलिटी में पर्सन स्टार्ट, सो इन डिरेलमेंट ऑल्सो पर्सन स्टार्ट्स फ्रॉम ओरिजिनल टॉपिक, इन टेंजेंशियलिटी ऑल्सो पर्सन स्टार्ट्स फ्रॉम द द ओरिजिनल टॉपिक, बट in derailment person never comes back. In tangentiality, in between person tries to come back, in between he or she tries to come back, tangential to the original topic. And try to understand the English. Okay, so he or she is tangential to the original topic, they in between try to come to the original topic, then again they go, they touch and then they go, they touch and then the original topic then go. But in derailment, like a train got derailed, they never comes back. In circumstantiality, आपने पूछा कि भाई मुझे वो रास्ता बताओ, मुझे वहाँ पे जाना है, पर्सन विल टेल he will achieve the goal, so he or she achieves the goal, but वो आपको unnecessary tedious डिटेल्स इतनी ज़्यादा दे देंगी कि उस डिटेल की आपको ज़रूरत नहीं है। सो हम कई बार बोलते हैं ना, डोंट बी circumstantial. So circumstantiality also part of the formal thought disorder. Okay, thought block, suddenly stoppage of thought, patient अचानक से भूल जाता है, thought block. So that also I discussed in detail in my videos, and in classes also will discuss. एक ध्यान रखना, derailment किस में मिलता है यूजुअली? शिजोफ्रेनिया में। ओके, एंड आपका एक होता है फ्लाइट ऑफ आइडिया भी डिरेलमेंट जैसा ही होता है कि पेशेंट गोज फ्रॉम वन टॉपिक टू अनदर टॉपिक। बस ध्यान रखना कि फ्लाइट ऑफ आइडियाज मेनिया में मिलता है, डिरेलमेंट शिजोफ्रेनिया में मिलता है। फ्लाइट ऑफ आइडियाज में क्या होता है? प्रेशर ऑफ स्पीच. डिरेलमेंट में नो प्रेशर ऑफ स्पीच. तो इन फ्लाइट ऑफ आइडिया पर्सन हैज अ, इन फ्लाइट ऑफ आइडियाज, flight of ideas, it is found in mania, and there is a pressure of speech. There is a pressure of speech. Okay, speech. In derailment there is no pressure of speech and it is found in schizophrenia. It is found in schizophrenia. ये आपको ध्यान रखना. Clear guys? Good information. Are you enjoying? Okay. So this is the answer is derailment. Next is a 20-year-old girl presented with over familiarity, flight of ideas, elevated mood, increased sexual desire, pseudo hallucination. What's the most likely diagnosis? Please tell. Number 19. Mania, hypomania, cyclothymia, schizophrenia. Please tell. Yes, the answer will be yes, mania. Answer will be mania. Mania में बस याद रखना यार, mania में आपको क्या पूछ सकते हैं कि एक इम्पोर्टेंट यहाँ पे मैं आप लोगों से डिस्कस करना चाहूँगा. सो mania में we have a these all symptoms: more talkativeness, elated mood, flight of ideas of the grandiosity, person having an increased sexual desire, increased energy, decreased need for sleep, patient having a in mania decreased need for sleep. So in depression also person doesn't want having a sleep disturbance, but in depression patient wants to sleep, but in mania person doesn't want to sleep. Okay, yeah, decreased need for sleep, at least 3 hours sleep is more than sufficient. Okay, in mania we say that according to ICD and DSM, in ICD and DSM we say that three criteria is sufficient. DSM also said 3 criteria. Out of these criteria, at least for 1 week. So schizophrenia 1 month, ICD 6 months, DSM. Depression, DSM and ICD both 2 weeks duration criteria. In mania also ICD and DSM both 1 week criteria. 3 criteria out of these criteria. But DSM also says that if irritability is if we counting as a criteria, then we need 4 criteria instead of 3. So irritability is not a persistent manic symptom. So if you counting irritability as a criteria, then you require 4 instead of 3 for 1 week. Okay, and hypomania का diagnosis कैसे बनाते हो friends? You up to 4 days. So ये ध्यान रखना, up to 4 days hypomania, and 1 week or more is what? Mania. Okay, yeah. एक ये ध्यान रखना, bipolar disorder type 1 and bipolar disorder type 1 आपको पता है क्या? डिप्रेशन प्लस mania, and type 2 is what? Depression plus hypomania. So depression plus mania is type 1, depression plus hypomania is type 2. In type 1 guys, please remember, even one manic episode is sufficient for making a diagnosis of bipolar disorder type 1. One manic episode is yeah, you need to be manic. Yeah. No, you should not be need to be manic, Atul. In manic you will not able to study. You will think that I know everything, sir. so no need to study. Okay, so don't be manic, be fully conscious, but yes, believe in yourself that yes, I can do it, I will do it. Okay, because exam is not only about knowledge, exam is about how to use that knowledge in examination hall, guys. Okay, so that is very important. So be fully conscious, believe in yourself, whatever you know, believe on that strength, hit properly, and then we'll see. Life is a bigger exam, so this exam is nothing, है ना. अभी आपको लग रहा है कि पीजी हो जाएगा, पता नहीं क्या हो, फिर भी लगेगा कि अच्छा तो ये है वो. सो दे इट्स लाइक लाइक आवर प्रोफेसर यूज्ड टू से कि दिस लाइक मेडिकल दैट आवर प्रोफेशन इज नॉट अ प्रोफेशन, इट्स अ वे ऑफ लाइफ, है ना. तो जब लाइफ ही ऐसी है तो जस्ट इंजॉय इट. ओके, डोंट थिंक टू मच, जस्ट डू व्हाट यू कैन डू एंड थिंक व्हाट इज इन योर व्हाट यू कैन चेंज. यूजुअली हम पेपर कैसा आएगा, स्टूडेंट पूछते हैं सर पेपर टफ आएगा कि नहीं आएगा. यार किसको पता है टफ आएगा कि नहीं आएगा, तो डोंट थिंक अबाउट things which you not in under your control, just think about the things which are in in your control. okay एक यहाँ पे एक इम्पोर्टेंट बस मैं आपको बताना चाहता हूँ एक दो लिथियम के बारे में. लिथियम यार, इफ लिथियम दे वॉन्ट आस्क इन एग्जाम, इसका मतलब पेपर कैंसिल होगा. वन क्वेश्चन विल कम फ्रॉम लिथियम. अब लिथियम के बारे में थोड़ा सा डिटेल में आपको बताना चाहता हूँ. इट्स अमेजिंग, इट्स अ वेरी वेरी इंपॉर्टेंट ड्रग. ओके, लिथियम पहला पॉइंट, इट्स अ एंटी सुसाइडल. आपको काम की बात मैं बताता हूँ. इट्स अ एंटी सुसाइडल मूड स्टेबलाइजर. तो यही एक मूड स्टेबलाइजर है जिसमें एंटी सुसाइडल प्रॉपर्टी होती है. पहला पॉइंट, हाफ लाइफ रफली 1.3 days. आफ्टर 1 year it become roughly 2.4 days. ओके, हाफ लाइफ. दूसरा, ये क्या होती है, इसका नैरो थेरापेटिक इंडेक्स होता है. नैरो थेरापेटिक इंडेक्स मतलब इवन माइनर इंक्रीजिंग द डोज इट कैन कॉज टॉक्सिसिटी. ठीक है, इसलिए इसका आपको लेवल चेक करवाना पड़ता है. तो लेवल हम कब चेक करते हैं? लेवल हम चेक करते हैं, एक स्टडी स्टेट लेवल होता है कोई भी ड्रग का, कि एक जब आपने आज मेडिसिन दी, लिथियम दी, बिकॉज ऑफ हाफ लाइफ उसका मेटाबॉलिज्म हो जाता है, फिर सेकेंड डे आप देते हो तो उसका लेवल फ्लक्चुएट होता रहता है. आफ्टर वंस द ड्रग अचीव द स्टडी स्टेट लेवल, उसके बाद में उसका जो लेवल है वो फ्लक्चुएट नहीं होता, कांस्टेंट रहता है. ठीक है, तो वो आपको any drug level you want to check, you have to check only after once the drug have achieved steady state level. ठीक है, तो हम कितने दिन के बाद चेक करते हैं? आफ्टर 4 to 5 days. पर्टिकुलरली अगर आपको पूछेंगे तो आपका आंसर क्या होगा? 5th डे. 5th डे. आज आपने लिथियम शुरू की, आपको 5th डे लेवल चेक करना. कितने उसके बाद में चेक करोगे आप? इतनी देर के बाद में आप पेशेंट को बोलोगे मॉर्निंग में आप 10 AM लो, नाइट में 10 PM लो. 5 days आपने लिया, आपने देखा कि उसका लेवल आफ्टर 12 hours of last, आफ्टर 12 hours of last dose. ओके, आफ्टर 12 hours of last dose. ये आपको ध्यान रखना है. आपने नाइट में लिया, मॉर्निंग में मेडिसिन लेने से पहले आपको लेवल चेक कराना है. इसका कितना होता है? एक्यूट फेज में 0.6 to 1.2 मिलीमोल पर लीटर, एंड प्रोफाइलेक्सिस फेज में कितना होता है? प्रोफाइलेक्सिस फेज में 0.6 to 0.8 मिलीमोल पर. ये याद रखना. साइड इफेक्ट्स आपको पता है, मेमोरी डेफिसिट, अटेक्सिया, डायरिया, एक्ने, सोरियासिस, नेफ्रोजेनिक डायबिटीज इंसिपिडस. नेफ्रोजेनिक डायबिटीज इंसिपिडस हम कैसे ट्रीट करते हैं? थायजाइड से, पोटेशियम स्पेरिंग डाययूरेटिक, अमाइलोराइड एंड स्पाइरोनोलेक्टोन. ओके, ये आपको सारा ध्यान में रखना है. ये क्लस्टर हेडेक में भी ये दी जा सकती है. आपका ये ल्यूकोसाइटोसिस करती है, इसलिए ट्रीटमेंट ऑफ न्यूट्रोपीनिया में भी हम देते हैं, माइग्रेन में भी देते हैं, है ना. अल्सरेटिव कोलाइटिस में भी इसके कुछ एविडेंस है. सो लिथियम इज अ वेरी 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 इंपॉर्टेंट ड्रग. ओके, नो, नॉट आफ्टर 24 hours, इट्स आफ्टर 12 hours. ये ध्यान रखना, ये गलती मत कर देना। इट्स आफ्टर 12 आवर्स डियर, नॉट 24 आवर्स, इसलिए ये क्वेश्चन बार बार पूछा जाता है। ओके, सो समबडी इज राइटिंग 24 आवर्स, नो इट्स आफ्टर 12 आवर्स। ओके ओके, आपको वैसे जो टेराटोजेनिक साइड इफेक्ट पता ही है, एब्स्टीन एनिमली। इसमें एक क्वेश्चन और मैं बता देता हूँ कि अगर आपको पूछें कि प्रेगनेंसी में कौन सा मूड स्टेबलाइजर सबसे सेफ है, पहला प्लीज याद रखना लेमोट्रिजिन। लेमोट्रिजिन इज अ ड्रग ऑफ चॉइस इन प्रेगनेंसी। अगर लेमोट्रिजिन ऑप्शन में नहीं है, ऑक्स कार्बाजेपिन। ऑक्स कार्बाजेपिन ऑप्शन में नहीं है, लिथियम। okay, please avoid the valproate and carbamazepine. So first choice lamotrigine. If lamotrigine is not in option, then oxcarbazepine. Oxcarbazepine is not in option, then lithium. okay, yeah, ये आपको याद रखना है। अगर आपको पूछा जाए कि फर्स्ट एपिसोड ऑफ मेनिया, ओके, ड्यूरिंग प्रेगनेंसी, तो आप क्या करोगे, क्या प्रेफर करोगे, एंटीसाइकोटिक। तो फर्स्ट एपिसोड ऑफ मेनिया ड्यूरिंग प्रेगनेंसी, व्हाट यू विल प्रेफर, यू विल प्रेफर एंटीसाइकोटिक रादर देन मूड स्टेबलाइजर। उसके बाद अगर एपिसोड्स होते हैं देन यू गो फॉर मूड स्टेबलाइजर। ओके, बट वी हैव टू डिस्कस अलॉट, बट सब चीज़ें डिस्कस नहीं हो सकती। एक पॉइंट और याद रख लेना कि व्हाट इज डबल डिप्रेशन। डबल डिप्रेशन क्या होता है यार, डबल डिप्रेशन इज डिप्रेसिव एपिसोड along with डिस्थाइमिया। तो पेशेंट को डिस्थाइमिया की पिक्चर चल रही है एंड डिस्थाइमिया के साथ में डिप्रेशन हो गया, उसको हम क्या कहते हैं, डबल डिप्रेशन, व्हाट वी कॉल डबल डिप्रेशन। ओके गाइस, ओके चलो गुड। तो नेक्स्ट इज our next question is yeah, we have covered. So this is mania, and then a teen-year-old girl having intense craving for food, she eats large amount of food which is followed by self-induced vomiting. What is probable diagnosis? Atypical depression, bulimia nervosa, anorexia nervosa, binge eating disorder. Yes, answer will be bulimia nervosa. Answer will be bulimia nervosa. Answer will be bulimia nervosa. Yes. Why binge eating disorder, अतुल? Why binge eating disorder? देखिए, अब मैं आपको फटाफट बता देता हूँ, ये इम्पोर्टेंट टॉपिक है, सो आप इसको देखिए। पहला एनोरेक्सिया नर्वोसा। ओके, फर्स्ट इज व्हाट, एनोरेक्सिया नर्वोसा। सेकंड इज व्हाट, बुलिमिया नर्वोसा। बुलिमिया nervosa, and the third is binge eating disorder. Binge, okay, binge eating. Anorexia nervosa, bulimia nervosa and binge eating. आपको बस ये ध्यान रखना। एनोरेक्सिया नर्वोसा में क्या होता है गाइस, पेशेंट को लगता है दैट सी इज वेरी फेट, मेल फीमेल रेशियो इज 1:9, मतलब फीमेल 1:10, ऑलमोस्ट फीमेल में ये ज़्यादा होता है। इसमें 2-3 क्राइटेरिया हैं, आपको पता है क्या। फर्स्ट क्राइटेरिया इज व्हाट, बॉडी BMI अकॉर्डिंग टू ICD-11 कितना है, ICD-11 लेस देन 18.5, तो एक BMI का वो पूछते हैं। दूसरा आपका क्या है इसमें, बॉडी इमेज disturbance, body image disturbance. Despite being thin, patient think that she is very bulky, so BMI less than 18.5, body image disturbance. And the third is 3 months history of एमेनोरिया, 3 months हिस्ट्री ऑफ एमेनोरिया। आपको ध्यान रखना है कि ये जो नया है आपका ICD-11 और DSM-5 में से ये क्राइटेरिया रिमूव कर दिया, कोई ध्यान रखना। तो पहले 3 एसेंशियल क्राइटेरिया थे, बॉडी इमेज डिस्टर्बेंस, द बॉडी वेट लेस देन 85% और BMI लेस देन, पहले 17.5 था, अब 18.5 है। बॉडी इमेज डिस्टर्बेंस एंड 3 months है। 3 months जो न्यूअर क्लासिफिकेशन है उसमें से 3 months हिस्ट्री ऑफ एमेनोरिया का क्राइटेरिया रिमूव कर दिया गया। एक तो आपको ये ध्यान रखना। उसके अलावा पेक्यूलियर बिहेवियर, दे चॉपिंग द फूड, दे बाइंग द टाइम, खाना फेंक देते हैं, अंडर कारपेट छुपा देते हैं, दीज आर द क्राइटेरिया। आप बस आपको ध्यान रखने, और उसकी वजह से उनको क्या क्या साइड इफेक्ट होते हैं। उनकी बोन डेंसिटी कम हो जाती है, उनके जो गोल्डन हेयर हो जाते हैं, लेनुगो जिसको बोलते हैं गोल्डन हेयर, द बोन डेंसिटी कम हो जाती है आपका। ओके, एनोरेक्सिया नर्वोसा एंड बुलिमिया नर्वोसा, ये इसमें 2 इंपॉर्टेंट क्राइटेरिया आपको याद रखने। क्या? दैट binge eating and followed by compensatory behavior. Compensatory behavior like self induced vomiting, laxative वो यूज करते हैं जिसको हम क्या बोलते हैं, purging behavior. Okay, so laxative they use the self induced vomiting, purging behavior. So bulimia nervosa, so bulimia nervosa mainly binge eating followed by compensatory behavior and it is mostly purging type. एक चीज ध्यान रखना, एनोरेक्सिया नर्वोसा भी गाइस, it mainly we have what, mainly we have food restriction type, but ये आपकी पर्जिंग टाइप भी होती है कुछ एनोरेक्सिया नर्वोसा के पेशेंट, ये ध्यान रखना। So mainly anorexia nervosa is a food restriction type, but some patient of anorexia nervosa we also have a purging type. Bulimia nervosa we have a mainly purging type. ठीक है, anorexia nervosa में पेशेंट का क्या होता है, वेट लॉस होता है, ठीक है। बुलिमिया नर्वोसा में वेट क्या होता है, नॉर्मल। एंड बिंज ईटिंग में क्या है, पेशेंट हैज ओनली बिंज ईटिंग, नो कंपनसेटरी बिहेवियर, ठीक है। so इसलिए इनका क्या होता है, वेट इंक्रीज हो जाता है। तो ये ध्यान रखना, बुलिमिया नर्वोसा में वेट कम हो जाता है, सॉरी एनोरेक्सिया नर्वोसा में वेट लॉस हो जाता है, बुलिमिया नर्वोसा में वेट नॉर्मल रहता है एंड बिंज ईटिंग में वेट इंक्रीज हो जाता है, ठीक है। आप प्लीज ध्यान रखना, बिंज ईटिंग इज अ मोस्ट कॉमन टाइप ऑफ ईटिंग डिसऑर्डर, ये आपको ध्यान रखना, इट्स अ मोस्ट कॉमन टाइप ऑफ ईटिंग डिसऑर्डर, मोस्ट कॉमन टाइप, ठीक है। एंड एक अभी और याद रखना कि DSM-5 में नई कैटेगरी एक लेके आए हैं, अवॉइडेंट रेस्ट्रिक्टिव फूड इंटेक डिसऑर्डर, अवॉइडेंट रेस्ट्रिक्टिव फूड इंटेक डिसऑर्डर। इसमें पेशेंट का जो इंटेक है वो फूड इंटेक कम हो जाता है, ओके, डिक्रीज फूड इंटेक। Either patient doesn't like the taste, patient doesn't like the smell of the food, and they avoid the food, and there is also weight loss. ये नई कैटेगरी है, ये आप ध्यान रखना। अगर ट्रीटमेंट आपको ईटिंग डिसऑर्डर में मेनली पूछा जाए, वी गिव व्हाट, कॉग्निटिव बिहेवियर थेरेपी, एंड एनोरेक्सिया नर्वोसा वगैरह में हम सिप्रोहेप्टाडिन वगैरह भी देते हैं, एपेटाइट स्टिमुलेंट्स। ओके गाइस, तो आंसर क्या होगा इसमें, आंसर क्या होगा, बुलिमिया नर्वोसा। A woman who is 4 days postmortem presented with tearfulness, mood swings and occasional insomnia, what is likely diagnosis? डायग्नोसिस ऑलरेडी वी डिस्कस्ड. 4 days मैंने दोबारा से बताया आपको, पोस्टपार्टम ब्लूज, पोस्टपार्टम ब्लू. ओके, या तो हॉस्टल का फूड. ओके, द पोस्टपार्टम ब्लूज. ओके, so this is the guys, we are having a, okay, we are having these MCQs. I tried my best to cover the as much as possible. I hope you enjoyed this session. But yes, again I will tell you, the psychiatry is not because I'm a psychiatry faculty, it's an important subject. क्योंकि आप देखो कि अगर आप डायग्नोसिस पे यूजुअली द साइकोफार्माकोलॉजी, दूसरे एरियाज आप देखोगे तो 8, 9, 10 MCQs मिनिमम दे आस्क फ्रॉम द साइकेट्री. सो इस सब्जेक्ट को आपको अच्छे से रिवाइज करना है. माइनर सब्जेक्ट की ब्यूटी ये है कि यू गिव द लेस इनपुट एंड यू हैव अ मैक्सिमम आउटपुट. ओके, या मैक्सिमम आउटपुट. सो प्लीज़ स्टे ट्यून एंड अच्छे से करो. जैसे मैंने बताया, ज़्यादातर अपने प्रीवियस ईयर MCQ के जो एरियाज़ हैं, हाई टॉपिक्स हैं, उनको रिवाइज़ करो. जो आपको कुछ लगता है थोड़ा बहुत इधर उधर से, एंड बीच बीच में पेपर देने की कोशिश करो. बिकॉज द 3 parts ऑफ एनी एग्ज़ाम प्रिपरेशन, वन इज़ यू read from the good concept from the authentic books, and then the second you revise it in a proper manner, 3-4 times revision, and then the last you try to understand that this how to use that knowledge in a examination hall. So the third part is also very important. Okay, if you have any personal query or something, you also can contact. मन उदास है, कुछ गड़बड़ है, something, we as a like physics wala platform, and I'm as a psychiatry faculty, will try to help you out. Okay guys, done. I hope you enjoyed. Okay, Atul, thank you so much. Yeah, I tried because in the small time it's not but yeah, I tried my best to give the maximum output. Important area we touched, and okay, I hope in from the part of your exam I will meet you with the good ranks. Best of luck from my bottom of heart. If anything I can help before that, we are there for you. Okay guys, best of luck. Thank you so much.